Okay.
Okay, so welcome everybody to the second business meeting of the NHS Lincolnshire Integrated Care Board public meeting. I'd like to kick off by stating a few apologies that we've got due to leave, absence, and people being unwell. First of all, Derek Ward and Andy, you're here for Derek. Thank you very much indeed. Apologies from Michelle Jolly and Pete Moore and Matt Gaunt. Emma, you're here for Matt. Welcome to the meeting. Sue Woolley, Sunil Indosha, who's on leave. Jonathan Montano, I believe, is at the funeral. Jerry, welcome. He's on screen. Welcome, Jerry. And also welcome to Steve Clapton, who is supporting Sandra on the health inequalities issue. So welcome. As you know, we also have a council meeting going on at the same time, and that's where Sue is. Wendy, you're a member of this board. Of course, I'm a member of the council. But thank you very much indeed for attending the Integrated Care Board here. So we have had a round of welcomes before, so I won't go around the table again. I think I've picked up everybody there. So I'd like to move to item 1.2, which is the declarations of interest. Are there any declarations of interest? It's the last meeting or anything on this agenda that you need to declare an interest on, please do it now. No, that's fine. Thank you very much indeed. Item 3.1.3 are the minutes of the meeting held on the 26th of July. That's our are they okay with everybody? For matters arising, including the action log. If we could kick off. If we could kick off with page 1. It's not the action log. Yeah, sorry. So we'll just do the action log figures first. First of all, which was about the performance report and additional information that has been delivered. So we're okay on that. So could we then just go back to the minutes then? And anything that isn't on the action log that you want to pick up, I'll go through page by page. Page 1, page 2. Drop me a by one if you want an update on anything. Page 3, page 4, page 5, page 6, page 7, page 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. Everybody happy with that public record? Thank you very much indeed. Minutes. Thank you very much indeed. Excellent job. Right. Back to the agenda then. Item 2.1 is the chair's update and overview. And I'd like to mention 7 things really. The first is to just pick up, of course, the nation's mourning in terms of the Queen's passing and thank the NHS and care staff for all of their work during the bank holiday. And I think there was some excellent work undertaken during that Monday where services were in the main kept running and moving And it was left to, frankly, the discretion really of what's the local level about what services we should try and continue to provide, balance that with what staff also very position. So as well as respecting, obviously, this morning, we also managed to continue providing services to people. So that's good. Second thing, I just wanted to say the obvious, but to note the new Prime Minister and the new Secretary of State, Therese Kofi, and their emerging priorities. And John will say more of the detail in his Chief Exec's update. Thirdly, I just want to report that the first quarterly NED non-executive director sessions took place yesterday for all non-executive directors of the NHS organisations, the three trusts and the Integrated Care Board. We had a 2-hour session yesterday. It was, I think, very helpful. Hopefully non-executive directors feel that. And the main purpose is to have some free space to kind of debate, discuss, align priorities, and make what is, a very complex situation as clear as we can going forward. We've found a good modus operandi, I think, going forward. We'll do some deep dive into certain subjects, and I'm pleased to say that Elaine Bayliss, who's to everybody chair of UHLT and Community Partnership Trust, the Community Trust she's taken forward a paper that will bring back to non-exec directors about how we work together. CEO, Chief Executive colleagues also joined that meeting, will continue to join it, and I thought it was a really useful exercise, and we will continue so that we, partnership working in a non-hierarchical way will be the way that we get things done under the integrated care system. The fourth thing is to report that the NHS Lincolnshire ICB annual public meeting took place yesterday as well, and I'd like to, on behalf of you all, record our thanks to colleagues who sat on the CCG for Lincolnshire. Some of us who have continued into the Integrated Care Board, Jerry being one, but others who served on that clinical commissioning group, to thank them for all their work, and of course far more important to thank all the NHS staff who worked in the CCG for the work they did during 21-22, which was, by all accounts, extremely challenging, as we all know, and very successful. So thank you to that. Fifthly, I'd like to note that I'm chairing the Lincolnshire Leadership Group tomorrow. This is a group of Lincolnshire leaders, CEOs, chairs, again, which is more executive, about our key priorities, again, that John will take us through, and I feel we're beginning to get a head of steam up. I know this is only the second business meeting of the Integrated Care Board, but important that you know that we have that group up and running. Particularly, I'd like you to note that John and I received a letter from some senior primary care colleagues, that's in general practice, in pharmacy, dentistry, optometry, about completing the establishment of the new clinical leadership arrangements. That letter came in on the 31st of August, and this has the letter's been responded to. Meetings have taken place, and I think it's been well received, and there's now action to get those clinical leadership arrangements sorted out as quickly as we can, And I think, John, you might want to say more about that, but you and Sunil and various other members of the leadership team have been meeting with representatives from primary care at scale, and hopefully now we have sorted that and got some movement to get that resolved and sorted out. And then finally, just to say that John and myself have been invited to Lincoln Castle on the 30th of September by the leader of the council to a civic celebration, which is the Lincolnshire Day, Civic Day celebration. And Dawn, you'll be attending on the Integrated Care Board's behalf, and thank you for to do that as well. So they're just some of the things that have happened in the last. Now we'll be going to a bit of detail in quite a few of those, particularly the changes in the government. And before I do that, is there anybody wants to raise with me in terms of the chat update or what's going on before we go to the stuff? Thanks very much, Lee. So let's move to the chief exec's update and overview. John.
Thank you, Andrew. Good morning, everyone. So quite a few things just for me to highlight to you. Firstly, on the back of Andrew's comments there, I just want to say a little bit more about the Secretary of State's position in terms of her priorities. I think you'll all be aware that last Thursday she stood up in the House of Commons and launched the plan for patients. That she's been very sort of crystal clear about the ABCD approach in terms of ambulance handovers, backlog, care, and the D is doctors and dentists. Doctors, I think it's really general practice, and has very sort of clearly raised expectations in terms of NHS performance and focus on these immediate priorities. Clearly, they reflect the priorities of the public, and I think people will say these are all things that we want to get right for the population of Lincolnshire that we serve. My kind of assessment of where we are at the moment, and we'll no doubt get into this more in the performance report, is we know that Lincolnshire has been and remains really quite challenged around the ambulance handover position. Whilst we're far from being the most challenged in terms of performance in the country, we are in a very uncomfortable position. We know that is causing the care for patients to not be as good as we would want it to be. So we've got a lot of work to continue to do in terms of ambulance handovers. As you can imagine, there's been a vast amount of work and effort that's been underway for a long time in relation to this. Our colleagues at ULHT and EMAS in particular have been doing a huge amount of work, but this is a whole system issue. So I suspect that this will come back to the board on a regular basis. In terms of B for backlog, Lincolnshire is one of the best performing systems, not just in the Midlands region, but in the whole of the country in terms of elective backlog catch up. We were one of the very first to meet the 104-week wait target and continue to make excellent progress on the 78-week target. There are, of course, a lot of challenges in our doing that. But that's a sound position that we're in at the moment. Hell of a long way to go, of course. And the other key backlog, I think, is in relation to cancer. As we've previously discussed, we do have an issue around colorectal cancer. There's been a lot of work undertaken on since we last met as a board, and Claire, you may refer to that in your update. When you look at our performance in relation to most other cancer sites in around, it's not a bad performance at all. The colorectal issue, I think causes more than 50% of all of the sort of backlog challenges that we have. In terms of C, care, you all know that we've been working really closely with our colleagues in adult social care for a long period now, in terms of discharge and flow, that we've already been putting in place quite a number of additional sort of investments in relation to that in recent months. The announcement the Secretary of State made last week was for £500 million to be made available to support this winter. There are no details yet in terms of how that is going to be deployed across the country and what the expectations and targets are that will come with that. Hopefully that will come out in short order. Clearly, I and Glenn Garrett and others will be all over that as it comes out. We'll be looking to deploy it in the best interest of the population of Lincolnshire. Now, just in broad terms, we're about 1.5% of the population of England. So 1.5% of 500 million. I think, Emma, is £7.5 million. So that's quite a considerable investment that's being made. We understand it's non-recurrent at the moment, but we need to see where we go with that. So that's where we are with C. With D, we know that when you look at the 84 general practices across Lincolnshire, their average performance is really decent, actually, in terms of how many patients they see, particularly how many more compared to pre-pandemic. How many patients are able to be seen on the day, that's well over 50%, and how many are able to be seen face to face, which is still over 50%. That compares pretty well, I must say, with most other parts of the country. But we know that within Lincolnshire, the average masks a whole range of performance. And we have some practices who really are struggling, who are working hard to support, and others who are up there amongst the best in the country, frankly. So I think that our work really is about how we work with those practices who aren't where we would all want them to be, where they would want to be in that respect. But there's no doubt that the amount of time it takes to pick up the telephone and patients being seen within 2 weeks we will keep a very sharp focus on that. Clearly, we need to work with our colleagues in primary care, general practice to do so. And finally, in terms of dentists, I don't think it's any secret that Lincolnshire is massively challenged in terms of access to dental services. We're far from alone in the country. And we know that in our county, the further east you go, the more difficult that becomes. So we do need to provide more details in relation to all of that. So I think this ABCD immediate operational short-term focus is clearly going to remain hugely significant for us. I thought it was interesting to note in the plan for patients that there was mention of prevention, joint working and partnership across systems. So we'll need to work out how we keep all of that in a good place. Alongside that, nearly a fortnight ago now, we had our sort of set piece quarterly review meeting with the regional director and his team. That's called the quarterly system review meeting, QSRM, and you'll see in the pack I've attached the letter that they've subsequently sent to that. A lot of very positive noise and encouragement from the regional team to Lincolnshire, acknowledgement and thanks for all of the good work that we and our teams are doing. Within that, obviously some really clear points around what I've already mentioned, around ambulance handover delays, aspects of cancer, and in addition the financial position as well. So again, that's there for for the public record. The way that I describe the immediate priorities of what I call 3+1, 3 clinical priorities of urgent emergency care, ambulance, handovers, and cancer and elective. Those are the 3. The +1 is the finance. So however you describe these things, I think we all need to be crystal clear that these will sit very much at the front of our minds and our actions over the next 6 months. In terms of our winter plan, Claire has been leading a process across the whole of the system. That's still ongoing, but excellent progress, I must say, is being made in relation to that. Claire, you might just want to touch on that in your update as well. And what I've already described sits right in the middle of our winter plan priorities. What we need to see as an integrated care board is the totality of all of the capacity that's available to us across the system. So we need to be able to see everything that's happening in the community to help people stay healthy and well at home. What our general practices, our community health services, our social care colleagues are doing in that regard. We need to have full visibility of how ULHT are managing A&E and medical beds and discharge and flow. And equally, we need to be able to see as a board the totality, all of the activity that's underway to help with discharge and flow from community health services, social care services, third sector, and so on. So that's what our winter plan needs to enable us to see, alongside having a very sharp focus on the handovers, cancer, and so on. Other things to share with you. The provided collaborative stock take exercise is now complete. Actions are being progressed in relation to that. The most significant one for us as ICB board is how we're going to accommodate the people and digital system responsibilities within our frame. And that's a piece of work that will certainly be completed by the time the board next meets. We've also very recently commenced and this is us as a system, a review of the structure of NHS provision in the county. I've shared with the board what we call the narrative in terms of reference for that. That work has literally just started yesterday and will progress over the course of the next 3 months or so. So very, very early days into that. The NHS England are continuing to work through how they're going to reduce their headcount by 30 to 40% and their new operating model. Whilst more detail is awaited on that, I think we can expect as an ICB that we'll be asked to take on more responsibilities, probably sooner as well. So I think we just have to sort of hang on to our hats in relation to that. We know we're taking on the pharmacists, optometrists and dentists next April, and some specialised commissioning responsibilities are coming our way as well. Sandra's sort of leading that process for us, but I anticipate that greater responsibilities will be coming our way over the course of the next 12 or 18 months. The COVID and flu vaccination programme is now in full flow. We've got off to a great start in Lincolnshire, I must say. Massive team effort, of course, in relation to that. It is COVID and flu, slightly different sort of delivery mechanisms for each. But I just wanted to say that that is now moving forward. Interestingly, one of our MPs, Caroline Johnson, who's a junior health minister, is actually has vaccines as part of her ministerial portfolio. I understand she's interested in coming and visiting one of our sites early next week as well. And then just two final things. Sorry, not quite there. Not to is say that last week the ICB executives considered the work we're doing in terms of supporting working with armed forces. We decided that we will sign what's called the Armed Forces Covenant. The CCG actually was a signature to that previously, so we will sign on that. I just wanted to note that. In addition, we're going to sign up to the Defence Employers Recognition Scheme, and we discussed a range of actions that we're going to progress in relation to that. I understand that our 3 trusts are all sort of signed up to those and sort of cracking on with that. And we do a lot of work clearly to support military families and veterans in the county. LPFT, for example, I think Sarah, you lead veterans mental health for the whole of the Midlands region, and other parts of our services, for example, on maternity services, work very closely to support military families as well. So I wanted to share that with you all. Just to say, Andrew, in relation to the primary care letter that you mentioned, I have regular meetings with the chairs or medical directors of the 4 professional care committees. That's called the 4 Pillars meeting. Jerry, as our non-executive director who leads on primary care, is in that as well, along with Sarah, Jane and Sandra and colleagues. Just to say, we did touch on that letter when we met recently, and I anticipate that Jerry and I will be having a meeting with senior primary care colleagues as probably sort of middle to the end of August, in terms of progress that we're set out we'll make in relation to the actions from that letter. And just two final brief things to say that in terms of ICB board development, you recall a month ago we had the Empower session, continuing to work with Empower on all of that. Andrew, I'll update you over the next week or so in terms of where we are with that. And of course, we have our next OD session as a board lined up for the 1st of November. So just let board members know that all of the actions are progressing in relation to that. And also to note that we have the first ever meeting of the Lincolnshire Integrated Care Partnership this afternoon, as well as the Health and Wellbeing Board. So we're looking at the terms of reference, department guidance, and importantly, how we're going to develop our integrated care strategy draft piece, or is it, or initial interim. I'll get it right one day by the end of December. So we'll hear a bit. Some of us will hear a bit more about that this afternoon. And we have a workshop for the ICP set up for the 2nd of November. We'll be progressing that a bit more. Thank you, Andrew. Happy to take any comments and questions, of course.
Thanks very much, Lydia. I saw Jerry was looking at me quizzically, but I realised she's frozen. It's not the best pose, is it?
No, it's frozen on the screen here, but it hasn't frozen on the screen on the system.
Oh, right,
It's moving around.
You are moving right.
I can see it.
I'm seriously worried now, Andrew, as to what on earth I look like.
Profound.
Okay, well, that's good that you're moving behind that mask there. That's great. So, thanks, John, for that update. Obviously, a massive amount going on, and as an ICB and all our organisations within the system, really important. First thing I said is this operational delivery. You've got a really, difficult winter coming up. That's frankly already started, and we're just going to have to keep biting away at these ambulance turnovers, colorectal backlog, care sector, and the finance. I mean, that's the, we've got to get into good shape, as best shape we possibly can, because as I said, if we can't deliver, we can't get out. We can't get out and do the development stuff easily because it dominates. So I know how much work is going on that. Any comments, please, from the board? Dave, do you want to pick anything up to do with primary care or anything, or how the vaccination program's going from your point of view, or
I think as John said, I think primary care in Lincolnshire performs pretty well. There's certainly pockets where we've got difficulties, but overall, I think we do perform well, and certainly the targets that Fraser Coakley's suggested in terms of same day access and unique access. Most practices in Lincolnshire already meet those targets quite comfortably. There are some that would struggle.
Yep.
And again, vaccine programme, I think we've had a fantastic start. I think there's some evidence that the uptake seems to be a little bit lower in some of our health and care workers than I would like.
Right.
So I think there's some work that we need to do on that. But certainly, our care home residents and our older patients seem to be wanting to have their, in many cases, 5th booster. I think that's a really good start.
Excellent, excellent, thanks. Something else that was, sorry, any questions? Julie?
Just tying it in with the flu vaccine, because actually there's quite a lot of concern, isn't there, that flu will be quite endemic this year and a real issue. So are we trying to tie in the flu and COVID together?
I would say it's really difficult to do that, actually. When we, most 90% of flu vaccinations are given in practices, and we're actually pretty efficient at it now. So, on a typical Saturday, we will give 800 flu vaccines. Now, if I try and tie that in with COVID vaccines, it's absolutely impossible. And actually, some of the systems that we need to use for COVID vaccines are actually quite clunky. So it'll typically take 3 minutes in terms of admin to sort of COVID vaccine out because of the questions you have to go through. Whereas a flu vaccine, we just book them in a minute and they're out. So actually tying them together would probably delay the flu vaccination program, and that's the last thing we want to do. So it sounds great in theory. In practice, it's not. And the other thing is, the way flu vaccines are procured as well. So most practices purchase their own flu vaccines. Yet we've got 3 large vaccination sites who have no flu vaccines at all. So the idea that you can co-administer, unless there's a very significant change in the way vaccinations are provided, certainly for this winter, it just wasn't practical.
Maz and then Martin.
Yeah, and just to say, so slightly different for staff, we are offering the workforce the opportunity to either have both at the same time or to have them separate. So we want to encourage as much of the workforce to take up the vaccine. So giving those options to the workforce.
Thank you. Martin.
Just to pick up on flu, Julie, really quick point, but we did exceptionally well on flu last year. So I've got good confidence that we keep the same level of figures. So both uptake from good people in Lincolnshire for flu was really some of the highest in the East Midlands. So was our staff uptake, was we monitored that quite closely. It was about 86 last year. It's too early this year to get the figures, Julie, but we've got 30,000 slots at ULHG to offer across all of our care partners. So I've got good confidence. Now the staff are going to be offered flu and COVID vaccine simultaneously. And just that last bit with Dave's point, some of it's just logistics. The delivery mechanism for flu vaccine is not the same as COVID. So it won't necessarily arrive into the surgeries at the same time. So even if they've got the best of intention of trying to do it, and some surgeries are, to be fair, or trying to, unlike kind of public messaging on it, it's made some people think it's really simple. Actually, it's really complicated. So it's not that we're not trying to do it, but maybe I was going to mention
a bit worried about getting people coming in twice.
Get that, yeah, get that. But I'm pretty confident, only because we did everything we did last year. We plan to do the same again this year, and we got some really great numbers. So
just to check, Martin, 86% was above for staff vaccination.
Yeah, it was some of the highest in the East Midlands, Andrew.
It was above the regional average or the
Yeah.
national average for staff. Yeah.
For flu. Yeah.
I mean, I think that is very. That's
Yeah,
good.
that's
So we're-
That's
Yeah,
good.
yeah. So I think that's really good. So we'll run the same process again. Yeah. Okay.
And just to remind really quickly, we're right at the start of the staff flu, so a bit early yet, but every chance you get, colleagues, push it, please push it. So I think we really need to get our shoulders behind it this year to make sure we get good uptake.
Good. Okay. Any other comments?
Just a question for John. The quarterly review letter, kind of the tone of it is quite positive, and it feels very encouraging. So I'm just interested, is this something that will continue Are we going on with the quarterly reviews with the RIGI?
Yes, it will. In fact, as part of the new sort of what's it called, Pete, the sort of assurance oversight framework, quarterly review meetings, just part of the operating model. We've had them for quite a few years now, from memory. I must say, some of the early ones, so I'm going back 2 or 3 years, if not longer, were very, very difficult. Performance wasn't where we wanted it to be. That was in the days of 4 CCGs and the previous regime and all of that. So certainly over the past, I guess it started before the pandemic actually, there was a growing sort of confidence in how Lincolnshire was working and the performance that was beginning to improve as a result of that. And we've continued that over the past couple of years. So things like, I mean, we did, the collective team Lincolnshire, did kick the vaccinations bit out of the park, really, which was fantastic in terms of reputation. The work that ULHT have done on elective through the pandemic, again, really, really strong. The continued focus on mental health transformation, really, really. So there's lots of good things happening. I think for me, it's great to have the support of region, but I don't think we should in any way doubt we've got some really difficult, hot, pointy performance issues, and this ABCD thing is almost what went before. This is what's we're going to be assessed on over the next 6 months, and as we'll hear later from Claire, there's going to be some quite challenging work that we need to do in that regard. So don't take any comfort from. It's nice to have, but don't take any comfort from that. Warm appreciation for the work we do.
Even as our sort of oversight framework moves, though, we don't feel we'll still have these quarterly.
Oh, we will, yeah. Every system has to have.
Yeah.
I was going to say every system has this
national
QSR. Yeah.
The ABCD, I'm not sure if we didn't put an E in to tie in with hospitals, but should that, and to some extent it is, be the real focus for the system and in the performance report, because that is key, as you said. So really all of the papers and everything on performance perhaps should really focus on those. There's an awful lot of detail in the performance report, as we'll come on to, but actually is that, I mean, that's for each of the providers in many ways. Our focus is on those 4 key areas and delivering that. And perhaps I just question mark, should that really be the focus of our performance report and what we have to deliver this year?
I would say it's the thing that we need to keep and will keep an extremely sharp eye on. I think our responsibility is also to pay attention to the whole as well. Learning disability health checks people see with severe mental illness. There's a whole range of other things that we need to pay attention to. So I think our challenge is to make sure we can accommodate the ABCD thing within the work that we're already taking forward. And as Claire will highlight through the report, in terms of the covering, I know, Claire, you will draw out where we are with the ABC stuff, so particularly draw that to the board's attention.
Yeah, I'll cover that a bit later. You've obviously read my notes, Judy, because I actually have structured what I'm going to tell you under ABC, which actually does cover some of what John said as well. So.
Okay, so we've got to move forward on all fronts. But for instance, the colorectal plan as part of the fee, I think the board is particularly interested where we're on colorectal, because that's, let's say, 50% of the issue. How do we sort it and so on? Yeah, great. Okay, any other comments? John, can you just come up?
Yeah, I just wanted to draw the board's attention that I've received a letter from a Mrs. Mary Reid that she wanted to submit to the board. It's in relation to neurology services. I'll not read the whole letter out, but generally she's raising the question about the relative priority that we're giving to neurology services and patients in the county. She's referring to the JSNA, and how that highlights challenges in terms of neurology. And she raises a few questions. Will we please ensure rehabilitation for neurology patients is included in our integrated care strategy? Will we please ensure that people with neurological conditions don't have to wait months and sometimes years for neuropsychology appointments and treatment? Physiotherapy is so important for bodily functions to regain what has been lost. Would you please ensure that physiotherapy is included from day one on the onset of the neurological condition in an integrated care pathway? So I wanted the board to note that letter. My view is that she raises some really important and fair points. I would propose that I write on behalf of the board in answer to her letter. Also, we offer to have a conversation with her about her concerns. I know Sarah J might just want to say a few brief words to just ensure that the board is cited on where we are in relation to these issues. If that's okay.
Yeah, thank you, John. Yes, we've had an ongoing conversation with Mrs. Reid and also colleagues of the Neurological Alliance, that is a support group for people living with neurological conditions. And the issues she raises were a prompt to why it was neurology was included in the JSNA. I think it is very fair to say that there is variation of service offer across Lincolnshire, and that's partly to do with the legacy of how the different CCGs develop those services, and people living with neurological conditions, the impact on their quality of life and that of their families is quite significant. And in terms of developing community service provision, I think that's an important focus of how we do develop that integrated offer, which is includes health, social care, and increasingly the third sector for this particular client group. The point she raises around local rehabilitation services is a very, very significant one for people who are affected by traumatic head injuries. And I don't think that we have got a clear strategy of how we support those patients who often have to go a long, long way away from home to be rehabilitated back into the community. And I think it is an area that we really need to look at. And Sarah, I can see Sarah putting I think it's probably again an area where we need to work very closely with colleagues around mental health.
Yeah, just to say, you know, neuropsychology, I spent some time with the team just a fortnight ago, and it is a tiny team. And I think as we're talking about social value and building social value in the system, I think this is an area where I think collectively we can really build some benefit by investing not a significant amount of money, but building some extra capacity, particularly around neuropsychology, that can get people back having a better quality of life, having some traumatic head injuries. So I just wanted to make that point. Thank you.
Okay, so what happens next? Will you? I mean, I guess you get quite a few, not complaints, but suggestions like this. But this particular one you wanted to bring here. Can you bring something back, or just keep us posted, or
I'm happy to keep the board posted. I mean, I think as a board we need to welcome, you know, comments and feedback from the public who we serve. So I'll, as I say, I'll write back to Mrs. Reid, and then I think we just need to work out how we do line up and knock off, if that's what we decide to do, the issues that she raises. But seems, as I say, I think we're all in agreement. There's very fair critique that she raises, and we do need to address those concerns. So I'll take that forward with the wider team. Andrew, thank you.
Thank you very much, Steve. So that completes your update and overview. Before we move to item 3, I forgot to say that Sarah Fletcher from Health Watch is not here. And welcome, Dean. Do apologise. Sarah, I left you out. Welcome to you. Okay, can we move on to item 3, key updates and public health? Andy.
Certainly, thank you, Chair. Yes, so I'll just talk you through where we are first of all with the current COVID-19 incidents. It's obviously fairly clear to most of us that we've come through a peak in July, and in Lincolnshire we had our peak so towards the end of July, it's about a week or so earlier in the rest of the country, and that we've been in a declining picture since then in terms of the number of cases detected. And obviously the board will be aware that we're not testing in the population as once we were. So we're really looking at the relative difference in cases rather than the absolute compared to previous peaks. But things have declined 4 or 5-fold since that peak. So things have come down significantly, which is reassuring. Now, obviously, we are starting to see a cyclical pattern of increasing incidence with COVID-19. Moving towards the autumn and the winter, we'd expect to see an increase in all respiratory illnesses circulating. And so it is easy to anticipate we might soon be moving back into a growth phase with COVID-19 spreading again. There are some early indications in our local figures. The numbers now may be trending up again, albeit still at that low level. And there are some hints in some of the UK HSA's syndromic surveillance measures that we're seeing a slight increase in COVID-19, but also in influenza as well. Now, moving into influenza, obviously that's one of our key concerns, is that, as the board will be aware, for the last couple of flu seasons we haven't really had a significant flu wave in this country and in Lincolnshire. And that's been replicated in previous years in the Southern Hemisphere, but this year in the Southern Hemisphere there has been more significant flu activity, certainly in some countries. And that, you could therefore assume that we will see perhaps a similar picture in the Northern Hemisphere as we move into winter. It's not definitely happening yet. I think colleagues will be aware that there are some increases in some of the syndromic surveillance measures. So rhinovirus has seen an increase. There's some increase in cough and flu inquiries with NHS 111, but again, pretty small. We're not seeing all the magnitude increase. And in terms of the respiratory data mart surveillance system, which tests samples, there has been an increasing prevalence of flu A detected in samples in the last few days and weeks. So just starting to see signs that could translate into a significant flu season. But I have to say very clearly, we're not at that level yet. We haven't crossed any of the thresholds. But at this point, that's certainly probably the strongest possibilities you would see significant flu circulating this winter. That doesn't mean that we'll see a wave in the scale of, say, 2019-20, which was a very significant flu season, but perhaps more activity. I should say we did see some activity last year. Some of the syndromic surveillance measures, certainly, but it was shifted back a little bit. It was a bit later than we perhaps normally expect, in February, March time in the spring. The issue for us, obviously, is lack of community immunity because of prior infection having waned through those previous years. It is something we're concerned about. Obviously, vaccination and as you've heard, the vaccination program is starting up and running out for both COVID and influenza. So that's where we are with those conditions. That translates into some work, which I'll just highlight 2 or 3 other things that we're doing in public health, some of which are connected to that, others which are just for information, really. We are working with Sunil and the Clinical Care Directorate to look at risk in the urgent and emergency care pathway, specifically relating to flu or COVID-19 waves and the pressure that would bring. And they're doing some research and indeed looking at the literature around this, which does suggest, actually, for information, I suppose, that it's not normally it is normally population behaviours that actually result in specific timing of peaks through the winter period. So these things are pretty predictable in terms of timing, if not in terms of scale and severity ahead of the game. So we are likely to know when our peak days of activity will appear, and that's simply based on population behaviour as the main driving factor. So there's some good literature to support that, which we're working with the Clinical Care Directorate to get the best learning from and to plan forward as we can using the data that we've got. So that's some work underway. A couple of other points I just want to raise because it's very relevant. Colleagues will be aware that there is further significant investment from the government in substance misuse services, and work to implement that in Lincolnshire is underway and has been underway for some time. So that is still in train. We are looking towards a contract end date in June 24 for the integrated lifestyle service, and are going to start early conversations around the recommissioning process for that key preventative service for Lincolnshire, which obviously is part funded, or historically has been part funded by the CCG. So that's key work that we'll be looking to take forward. And indeed, as part of that, we are starting our 2-year pilot for a child and family weight management service, again targeted at reducing health inequalities and helping those that need the most help. And that is starting at the moment. Now first groups are starting. So there's a few highlights of the work that we're doing there. And obviously, Derek Ward, Director of Public Health, is still working across the 3 Lincolnshire local authorities, North and North East Lincolnshire as well. And we're looking for further decisions, I think, in the next month or 2 around the direction of travel of that programme. So probably all out safe now.
Yes.
Just to add a bit of context around the COVID situation, why it makes the vaccination conversation really important. So this time last month, we had about 40 patients in all of our hospital beds across the county with COVID. Just in the hospital, just alone today, it's 82. So that just gives you the sense that we are starting to see the trend upwards. Similarly, for LPFT, you've had a couple of outbreaks, and it's really difficult to manage it in those settings as well. So that vaccination of our health and care staff, but also the general population, who for most people think COVID has disappeared, is really important in our comms, I think, at the moment.
Martin.
Very quick question, Andy. We always track the Southern Hemisphere, don't we, to try and get a sense of what flu was like for them as they're heading out of winter. We're heading into ours, but what's the intelligence saying around that?
So some countries in the Southern Hemisphere, South Africa particularly, have seen a flu wave through their winter. And it's I don't think it's a scale that's particularly unprecedented. Having said that, I was looking at the research yesterday. It's not ubiquitous in the Southern Hemisphere. Again, it will depend on different countries' surveillance. South Africa have an excellent health surveillance system, and so good data from that intelligence that flu has been circulating. So we've not seen that in previous seasons, is the main take-home point for us. So we think globally, flu may be on the rise. It's likely to have an impact in the world.
Okay.
Yeah, you mentioned procurement of the integrated lifestyle services. Are we going to look for more tier 3 weight management services? Because that's something that we really do lack in
tier 3 and tier 4 indeed. And that's not normally folded into the discussion around the integrated lifestyle services. That's really a clinical service, but obviously, at present there isn't that. What I would say about the integrated lifestyle service is that really we'll be having those conversations, because although we're lead commissioner, it is a key preventative service for Lincolnshire, as I say, part funded by this board. Really, we will be going through a process of saying, what is our ambition for this service? What do we want to see, and what do we want to focus on? There is some stuff we might have a conversation around moving out of the integrated lifestyle service. We've not had these conversations yet, so this is slightly speculative, because it could fit better elsewhere, potentially with the additional investment in substance misuse. Alcohol could be one of those. But we can have that conversation. If there's other elements to bring in, obviously there needs to be funding associated with that. But it's absolutely right to have those discussions.
Andy, I didn't quite understand the substance misuse. Is it a bidded? Do you bid for this service nationally, or is it allocated per capita?
It's a national allocation per capita, and obviously Lincolnshire has a ring-fenced public health grant, which contains. And we have some certain statutory services to deliver. Substance misuse support is one of those. What we've seen over the last year or so, particularly with the previous administration, is a big investment in additional rolling out substance misuse support, which has turned into a significant expansion of sort of service delivery that we're now planning for over the next 3 or 4 years. It's really good, really positive to see this. It does mean that we can perhaps have some conversations to say about what other elements sit elsewhere. And I suppose one thing I should say, which would be very familiar to all, is that we are certainly looking in public health and across the wider local authority at inflationary pressures, and we'll be needing to have some thoughts going forward, and are having some early discussions around what that might mean, obviously, for service delivery going forward.
Good. Okay. Well, thank you for that public health update. That's Excellent, really good report. Can I move on to 3.2 and Health Watch? Dean, over to you. Please.
Yeah, no, thank you. Good morning, everyone. And yeah, in terms of Health Watch and sort of public feedback, you won't be surprised to know that dental access continues to be the most common concern that we're hearing about. You know, people struggling to find practices taking on new NHS sort of patients, regardless of, you know, wanting to seek you know, prevention care or urgent appointments. We're also hearing from individuals whose practices are no longer offering NHS dental services. We are sort of currently involved with the Lincolnshire dental strategy, which I think is a really good opportunity. Sandra's nodding over there because she's also involved in that. So which will give us a better understanding, a picture of, you know, what is currently available in Lincolnshire, and then obviously identifying, you know, those gaps and obviously future plans. In terms of sort of Health Watch work, we're launching sort of a campaign to kind of highlight some of those concerns, and in fact we're starting that off sending a letter out to all of our councillors and MPs, which you'll be getting in your letterbox for in the next few days, which really, yeah, is an opportunity to sort of highlight those issues, but it's also about including information, signposting and advice for patients that currently have, you know, problems, while obviously we try to, with the system, try to improve those concerns, but also raising it nationally, well as kind of locally. In terms of GP practices, yeah, phone access continues to be an issue, as we've talked about, but sort of something that sort of came up as well around sort of poor communication, but with the issues with people accessing services kind of outside of the county. So patients that will be our, you know, residents going out, you know, to Peterborough, Kings Lynn, Grimsby, and that kind of communication seems to be lost there. And I just wonder how, as a system, we kind of pick up those issues where our patients are going out of county. In terms of hospital, again, communication seems to be the big issue with you know, struggling to contact hospitals with and consultants around, you know, updates and queries around their current condition and where they are in that kind of that waiting list. And then the last thing I just wanted to raise was around the sort of wheelchair assessments. So we've been made aware through some patient feedback, patients now have to travel for that assessment, which was previously done at sort of patients' homes. Seems to be a sort of an odd change, and I suppose a larger question around inequalities for those that, you know, already have mobility issues. And I think one of the reasons that they gave for doing that was around sort of increased petrol prices and things. Well, obviously then that goes to the patient rather than that. So it's something I wanted to raise here. You know, I would obviously expect an answer. It might be something that needs to be delved into a little bit deeper, but I just wanted to raise it as it was something that came through.
Dean, thanks very much indeed. John, I'm going to look to you on those 4 points. I mean, we could spend the whole meeting on there. They're really good points, I think, but I just maybe a summary about dental access and what's going on.
Yeah, I mean, there's a lot of work going on, both to understand where we are in terms of access to dental services in the county and how we can sort of address these. Technically, at the moment, of course, it's NHS England who've got responsibility for all of this. I have had numerous conversations with the regional dentist and his team. Sam, as Dean mentioned, we've got a group looking at this internally. So I think at some point, Andrew, it'd be quite good to get this in front of the board, so we've got the facts of the matter rather than just the sort of probably time assessment. But we have got a very significant issue here. So, for example, the regional dentist in our last conversation was talking about a Golden Hello scheme that he is promoting across the Midlands, and the level of interest in it for people to come to Lincolnshire was very, very high. And he was talking about north of 30 expressions of interest, and he's anticipating maybe 2 or 3. So one of the things we can bring back to the board in due course is the extent to which those expressions of interest have actually materialised in some change there. So
can we hold it there
Yeah.
then? Because I think that's excellent on dental. I mean, it seems to me, and I guess the board would be the things that we are in control of and the things that are out of our control, and it's particularly there are national policy decisions that need to be taken on this, but there are other things that are in control. And I think particularly things in control where we can make a difference would be really helpful. So back to that.
on GP access, I actually think this issue about how long it takes to pick up the phone, I hear more about that from the people of Lincolnshire than rather what happens subsequently to them. It's that frustration. Of course, many people access digitally, and our practices are very well enabled to do that. And Dave, you've talked in the past about how that works in your practice, but when patients choose to telephone a practice, some practices within 10 seconds, others we hear anecdotally don't pick up within 10 minutes. So what I've asked Sarah Jane to do is to get a granular understanding of the performance of each of our 84 practices in relation to that. And clearly that sits alongside the digital access thing. So that again is information that will come forward, I think possibly into the primary care committee in the first instance, but no doubt that will be something that is this part of the ABCD, isn't it? As Dave was saying, and in the sweep across Lincolnshire, actually our performance in terms of patient access, activity, and all is pretty good. So it's going to be those sort of the hotspot areas that we need to particularly pay attention to. And if I could just pick up the other 2 points, the first is around the out of county. I think, Dean, in terms of how we deal with that is if you're able to share the patient experience details with us, then we can work that through. I must say that in terms of patients who access Peterborough and west of us, it's quite rare actually for issues to be drawn to my attention. I think it's fair to say north of us, so that's into north and northeast Lincolnshire, I think more concerns tend to be raised by the population about information flow, communication, all the rest of it there. But I think if we share with us, the details, and we'll work our way through that. Wheelchair assessment, I think it's the first time that's been drawn to my attention. Really, really helpful, I think. Claire, you might just want to say a word on that.
Yeah, so our wheelchair providers do 2 types of assessments. So they do a home-based assessment where they go out, but for some patients that's not possible because of the nature of the assessment. It does need to be done in the centre, need specialist equipment, hoisting, things like that. So it does vary. So if you let us have the intelligence, if people are not getting their home ones when they would have previously had them, that's an issue that we can take action on, no problem. But if it's actually that they've always come into a centre, then that would continue, and it's to do with the specialist nature of their assessment. Obviously, they're not the easy ones can be done at home. They pick that up. Sure, just pick up the other point, which was around backlogs, which I think we were referring to patients not getting the feedback from consultants about where they are. So we've done a lot of work with yourselves and with colleagues. We've got the waiting well information on the website. I guess we probably just need to push that out a bit more. Because, those waits are, as you know, we're trying to come down from 2 years. That's not going to be solved really quickly, and it's not very easy to say exactly when somebody will be seen. So, but we have got that information out there for patients to access.
Yeah, if I could just come back on the phone access, I think it's absolutely a problem in primary care, but there are solutions that are starting to emerge that I think will make a huge difference. So in my practice, we're just looking at a system that we've actually procured for Lincolnshire, and they've launched the ability to book patients to book directly into multiple different appointments. So, for example, cervical cytology, asthma reviews, COPD reviews, diabetes reviews, if they need a blood test. So all these different appointments, you can actually set your system up and literally bulk message people. So rather than all at the minute, all those people, when we bulk message them, all try and ring reception. And clearly, you know, if you've got 3 or 4 lines, they get crowded very quickly. But actually, for people who can use digital systems, so it doesn't apply to everyone, but you know, quite a large proportion of our patients can do that. They would literally be able to book directly into the appointment. They wouldn't go anywhere near the phones, nowhere near reception. That then frees up the phone lines. So these kind of systems are coming on stream very, very rapidly. And that's something actually you could put across all of our practices very, very quickly. And that would make a huge difference. So we're going to trial that over the next 3 or 4 weeks. So I'll let you know how that goes.
That's excellent. Yeah.
Just to add, because I think Dave's right, I think this is about looking at what goes through phone lines and looking at whether there are alternatives that can release some of that capacity. And the mechanism Dave's describing, you actually use for vaccine bookings.
Yeah, we do. Yeah,
and it worked really, really well. So that because we were very concerned about the volume of people ringing to book their vaccine, but actually using that mechanism. We didn't see that.
Well, typically, we last year was the first time we actually used this kind of direct booking system for vaccines. So prior to that, we would have been sending out something like 4,000, in my practice, 4,000 text messages, and they had to ring the surgery to try and get an appointment. So you can imagine, obviously we stagger it over numerous days, but you can imagine what happens to the phone lines. If they can book directly into an appointment, then you're losing that. But we can do that across the vast majority of our chronic disease type appointments.
So I think this is a really important point, David, that we could take action on and roll out once it's proven, you know, very quickly. Because once we get to this waiting thing, people forget what they're waiting. They just get angry at waiting, and we're back to where we were 15 years ago with the NHS. We waited for everything, and regardless of how good the service was, which is wait was the big issue. So I think if we could get on to that, that would be a great thing to do. And then I guess the population divided into those that can do that service and those that can't. And the service you provide about the people who are not digitally up to speed or need help, you know, we could boost that up a bit as well. That's a great service.
Once they've got it, they don't have to think.
And then they know how to do it. They can actually bring people. Okay. But yeah, the other thing is, I think it would be good for the 4 points you raised there to be action involved. That's okay. So they're thorny issues, and we won't come back with answers.
Can I just add about the wheelchair?
We need to make sure we're keeping right on top of them.
The wheelchair. That is going through. It's launching the just going into the elderly. It's going into the it's going into the ELSIS, the Lincolnshire Community Equipment Service in front. So it's all just being sorted at the moment and how it's going to work.
Okay, that's great. My guess is these will be action on to the you know, oversight assurance or sort of to the committees, but nevertheless, well, thank you very much, Dave. We'll raise that. Good. Okay. Good debate. Thank you, Matt. Yes.
Yeah, just very quickly, just to say that digital health have linked in with Health Watch in my organisation. Sarah reached out in relation to digital coaching. So what we can't do is be saturated, but we're linking in with Health Watch, particularly around how we help and support communities to really use digital as a first option where we want them and need them to.
I presume, I mean, it's too detailed, but presumably we get it off in one PCN and then gradually move it out, get it ready. You know, I don't know. I feel like too detailed.
It's not too detailed, but yes, I think there is something about you know, being very methodical and making sure that we test the systems and then when they're effective, roll them out. But clearly we will. I'm looking at Sandra. There is a challenges around making sure we don't create further health inequalities by putting all our efforts into the digital. So yes, roll it out, but in a way that's meaningful for the population.
Yeah. Okay, thank you very much indeed. Can we move on, please, to item 4.1, the first of our core purposes, health inequalities, and Sandra.
Thank you. I'll just do a very brief introduction and then we'll go into sharing the presentation if that's okay. So
Thank you, everyone. The purpose of the report we've shared with you today is just to highlight all the partnership work that has taken to date and the approach we've taken to the COVID vaccination, with the purpose really about us achieving as high an uptake as we can possibly achieve amongst all of our communities. So the report that you've received is with a lens on health inequalities. It's already been stated in John's opening start of the meeting about the fantastic progress we have already made on COVID vaccination. So this presentation today will take a look back at how that has how progress has been made in the lens of health inequalities, but also then importantly about our findings and the approach we're taking in terms of the autumn and our next steps. So I'd like to welcome Steve Clapton, who has been leading with colleagues across the system in the health inclusion. So if that's okay, the colleagues will share on screen. Hopefully technology will work.
Fingers crossed, thanks. And just those that don't know, I'm Steve Clapton, and I'm the locality lead on the vaccination programme.
You share it, Steve, then step off to send it live for you. Should be. We can sit in here, but you should be able to see it and attend. It's brilliant.
Okay, very fantastic. So as Sandra said, what I'm just going to talk through is the strategy that we've taken around health inequalities in relation to the vaccination programme. And this will focus specifically on the work that we did during summer 2022. So as we've from the very start of the vaccination programme, our goal has always been to increase uptake and have the maximum uptake that we possibly can do. And our strategy really focused on two tasks in relation to this, and that's providing access and encouraging uptake. Now, although this is around the health inequalities, this actually goes back to the very beginning of the programme in terms of providing access and encouraging uptake. The key activity when we went live in the very beginning was to identify key locations. Lincolnshire has a lot of issues that other systems don't due to the reality of the county. So actually making sure that we identified locations that were of an appropriate size and located effectively was really key to us delivering this programme. And that becomes even more crucial when we start talking about areas of health inequalities. Around the encouraging uptake, this was really around delivering a compelling message and encouraging people to come forward for a vaccine. I think it's safe to say that in the early days of the vaccination programme, this was almost done for us at a national level. As we've gone through the programme, that message has needed to subtly change. So in relation to the specific health inequality work, the key task for us around providing access was moving away from the fixed site model, which we operated through the early phase of the programme, albeit maintaining that, but we realised that we actually needed to go to a more local level, and that was going to be achieved through outreach and pop-up sessions. Really pleased to say that during the summer we had access to a vaccination bus. So this is a bus that had been used by Public Health as a mobile testing bus. Worked very closely with them to understand the locations that they've been to, where that was successful, and even more so than pop-up sessions, this allowed us to go to really rural local locations, which was absolutely key to the aims of the programme. And then what we also wanted to do was have focus sessions at our mass vaccination centres. So within Lincolnshire, we have two mass vaccination sites. We have one that was originally based during the early stages of the programme at Lincolnshire Showground, and one more towards the east coast at Princess Royal Sports Arena. And then around encouraging uptake, again, we work really closely with the engagement team at the ICB, who attend a number of engagement events. We wanted to understand what questions people were asking around vaccinations and how we could help support that. So we actually had a number of staff members that had worked at vaccination centres actually go out with that engagement team to actually answer questions that people would have. Maybe didn't feel comfortable having a vaccine straight away, but just wanted more information around that. We also saw this as a great opportunity to actually integrate with other health services. So specifically with Boston PCM, we did a lot of collaborative work with them. So making sure that patients who were wanting to sign up to GP practices also had information about the vaccination programme, and then wider services that they offered as well. So that was really key to us to make sure that we were sort of seen not just as a vaccination programme, but as part of the wider health programme as well. And then, as I've mentioned previously, the tailored communication, we wanted to move away from the mass message around vaccination just coming for a vaccine. We wanted to encourage particular cohorts where we knew that uptake was low to actually come forward, and to do that it had to be a really specific message with them. We worked really closely with a company called Pad Languages in collaboration with Boston Borough Council. They were doing some work with them, and that was really sort of focusing on certain communities and what messages were key to them. So hopefully you can see this, but the first one we did when we got past the Spring Booster program was do a real deep dive into the data. Now on this map, the darkest areas represent where we have the lowest uptake for first doses, and I'll come to why first doses are particularly important in a second. So that flagged 4 particular areas of the county. So there is just south of Lincoln City Centre. There's the area in and around Boston, the area near Wainfleet on the coast, and also Spalding. So when we did deep dive into each of these areas, what we realised was that the area on the coast and the Spalding area, we had quite a transient population, and that's due to the kind of work that takes place in those areas. So we did some work with GP practices, just do a deep dive to understand that cohort a little bit more. And actually what we found is there were a number of patients that weren't actually in the country at the time, so they were still showing us not in the first doses, but actually not long for us to get the first dose too. When we did the deeper dive into the south of Lincoln City Centre and Boston, it flagged up that there were 4 key findings that were preventing people from coming forward for the vaccinations, and those were the cultural factors and cultural identity. Literacy was particularly low in those postcode areas, and there was high levels of deprivation. So just to give some figures, in Lincolnshire's system, in the areas that are least deprived, the uptake for 50+-year-olds for first doses is 98% as a whole, and 98% for those eligible for booster doses. In the most deprived areas, that drops down to 93%. When we look at ethnicity factored in with that, now within Lincolnshire, room past white British, the next highest group is the white other group. For that group of patients, in the least deprived areas, uptake for first doses was 88%, and in the most deprived areas drops down to 58%. And when we look at booster doses, that just changed slightly. So for those that are eligible for a booster, it's 95%, then drops down to 75% in those most deprived areas. And that just links back to why I said that the first doses was particularly important. What we realised was that if people were coming forward for first and second dose, even in those most deprived areas, and regards to ethnicity, they would come back for another vaccine. So what we really needed to do was target those patients who hadn't actually come forward for a first dose. We're confident that once we actually encourage them to have a first dose, that they then want to come back and complete their course of vaccinations. So we talked about looking at the pop-up and outreach and using the mobile vaccination bus. So the way that we were going to judge our success criteria for this was looking at the number of locations that we went to, frequency of vaccination access points, and how we did that. So over the course of the summer months, so this is from mid-June through to the end of August, we actually went to over 35 different pop-up locations. So these range from community centres to churches to specialist clinics in hospitals. We work very closely with the maternity team and had a recurring clinic in the maternity centre. And we also wanted to actually have quite a high level of frequency in locations. We wanted to be visible to patients, so if they saw a vaccination centre one week, they knew that if they didn't want to come forward that week, they then could come forward at another time. So one of the key partnerships we had was with Lincolnshire Football Club, and we actually had a clinic there over a 6-week period every Monday, and that was a very successful clinic. With the vaccination bus, and we also had access to 2 other mobile units. So these were provided by regional colleagues. Essentially, these were mobile vaccination vans, which again just allowed us to go even more local, which was really, really key to the work we wanted to do. We could take those kind of vehicles. We took them to supermarket car parks, trying to capture patients. We took them to village shows, went to the Lincolnshire show. We could take them into marketplaces on market day. Really, really key to the work that we wanted to do. As well as going out to these cases, what we wanted to do was make sure that it was well communicated. So that the public knew where we were. So our comms team, led by Simon Hopkinson, were absolutely critical to this. So you probably all noticed over some of our social medias, particularly our Facebook pages, 4 or 5 updates every single day saying where our vaccination teams would be. We used the Lincolnshire Grabber site page that was updated daily, so anyone could log on there and see exactly where we'd be for the next 2 weeks. Worked really well, and we had really good feedback on that. In terms of encouraging uptake, so the way we're going to do this was based on making sure that the right materials were given to patients and population. Now, we did a lot of work with Boston Borough Council and PAB Languages, and what we realised is that the translated materials that were widely available, though it was a direct translation, it lost its meaning on that population. Particularly the Bulgarian and Romanian population actually said that the materials are out there actually made them feel alienated. It didn't encourage them to come forward for vaccine. So we worked really closely with that translation company to actually change the standard materials and actually get our own printed that we could take out to these venues and give to this population. That really changed attitudes. What we also did is at the engagement events, where we actually took translators with us. So those people where English isn't a first language and actually the message wasn't completely clear, they could come on, ask whatever questions they had. We had a translator there, we had a vaccinator there, and other members of the vaccination team that could give them as much detail as they wanted. And what I'm ready to say, so over the summer periods of those 8 weeks from mid-June through to the end of August, we vaccinated 563 people with first dose vaccines and over 2,000 patients with second dose vaccines. Now, these might sound like quite low numbers, but these patients have been eligible for a vaccine for 18 months at that point and hadn't come forward. So it was really that really localized work that made that possible. So as we've said, autumn campaign has started now. We've had a really good first couple of weeks, so we're just going into week 3 of the programme. It went live on the 12th of September, and how we're going to continue this approach into the autumn is actually have a blended approach between our vaccination sites. So we've got really good uptake with our PCN colleagues and community pharmacies, as well as maintaining 2 mass vaccination sites. What we're also looking to do is introduce a drive-through model into the programme to give us another access site. We've got access to the road safety partnership vehicle. Now, this is somewhere that we can actually take to different locations. It's not quite as agile as the vaccination bus or the mobile units, but actually it is much more viable to use in the colder months. Having people stood queuing outside the bus isn't ideal when the weather's likely to turn quite soon if it hasn't already. And then what we'll also look to do is utilise those popular outreach venues and pop-up locations that we did previously to make sure that we are providing access locally while still maintaining the offer of mass vaccination, which at this stage of the programme, when it's sort of just come online, we do need to have that mass capacity at sites as well. So it takes away that really local offer, a blended approach, so we can actually do both. The work that we did with PAB Languages, we want to use that learning going forward. What we do now is we have a much better idea of the preferred languages in certain areas of the county. So that means that any engagement work going forward, rather than it just be, here's what we have always taken traditionally, we now have it translated into specific languages where we know the uptake will be good. So we really build on that, continue to use translators where possible, where we know it's a certain cohort we want to forward to going forward. As Dr. Baker mentioned earlier, so we are able to co-administer flu and COVID vaccines together. That does bring logistical issues, but actually it is an option and it's something that the regional team are in favour of. So it will be up to individual sites to decide what that process is going to be. Obviously, we talk about the hospital hub and looking to do that for our staff. We also have a number of PCNs who are actually looking to use that model. We did have slight issues with the alignment of the delivery of flu vaccines and COVID vaccines, but I think all practices now have their flu, or certainly get them over the next week. So I think we'll see more of that in certain venues. And what we really want to do is, so although providing access was critical to the work we did over summer, it was actually the health promotion that actually gave us the best results. So it was those conversations with the population in terms of why this was crucial, allaying any fears that they may have, that actually made the biggest difference. Now, we've got 20 plus vaccination sites across the county. What we really want to do is utilise the people who are coming through those vaccination sites for wider health promotions. So we're going to work with our public health colleagues and other NHS colleagues to actually what we can do at vaccination sites in terms of promoting other services going forward.
Thank you. Excellent presentation, Steve. Thank you very much indeed for all your work. Thank you. Any comments?
Yeah, it's excellent work, obviously. I think the key thing I would highlight is that the central challenge around health inequality so often comes down to trying to solve the same set of problems. One of the key problems that we're trying to solve is how to engage people who feel marginalised or alienated from accessing health and care systems. Because obviously what will happen, and we know this from the literature, is that they will wait until they need to present to the agency and then they will go and present. We need them to uptake proactive and preventative care. Vaccination is a great example. So some of this work really needs to be used and disseminated across the system in terms of that specific learning, but how to engage well with specific population groups. You know, that little salutary tale of the needing to get it retranslated in Romanian Bulgarian, because you know there's no substitute for being able to build trust, and people will know when somebody understands their situation, understands their language, and doesn't. And I think that's what was coming through from your about the health promotion there. So those are really valuable lessons that, as part of the health inequalities and health improvement approach, we need to be disseminating throughout the entire system, and stop everybody trying to solve those same problems where we've already solved or learned some lessons.
We can use that approach time and time again.
Exactly.
Yeah, great, smashing, winning.
Can I just ask, obviously me being a local member, we had a bus in Coolsby last week or the week before, last week, doing COVID vaccines behind the fire station.
That's the vehicle partnership unit, yes.
Yeah, it's just that if we could have more information where these are going out, because I had so many messages and phone calls. How do I get an appointment? Well, I didn't know because I didn't know it was there. But you know, I don't need to know. But it's sometimes helpful if we can have not just on Facebook and Twitter. Because a lot of the older people don't do Facebook and Twitter, do they? A lot of them do, but I mean, they don't at all. And also, I'm getting phone calls. When is Skegness going to be open? When is England going to be open? Maybe if we could just get a list of dates so that older people aren't panicking. You know, I've got an 84-year-old only wanting an appointment at Skegness because she can't travel. She's panicking because she needs to book herself in, but I can't find any dates of when it's going to be open. And I'm sure it is, because I know England's already open.
Yeah.
But it's just finding that information. If we could have a list, even in the doctor's surgery, so that at least we can put it out.
Yeah,
I
absolutely.
mean, it is good. I mean, they were at Wayfleet Market in the summer. It is good that they've been going out, but it's just that knowledge that they are coming.
Yeah.
Dawn, then Maz, and then we'll move on.
Just very quickly, really, really impressive, massively impressive, really good to hear. Do we have a system to capture how people, where they got their communication, so how they knew where to go or how they knew where to look up or where, so there's lots of sort of visible signs if you have a pop-up bus or whatever it is there every Monday, but in terms of people knowing or what prompted them, do we have a kind of capture of that information?
So we did over the summer. It was quite mixed results. We didn't get a lot of people feeding it back. It's just
Right.
oh, I knew you were here, and then really go into a lot more detail. The eventually touch I can sort of collate that into.
Just think if you know which communications work best, then out of this, yeah.
Maz, and then Martin.
Yeah, thank you. So just want to say thank you very much. Really interesting. And it's so great to see and hear from where we started to what we now know. And I think that's the bit for me. How do we disseminate this learning and capture it in a way that we can take it into provider organisations for public and patient engagement in a way that actually we don't have to struggle to learn what you now know. And I think that's the bit, isn't it? It's that lifelong learning. And as you continue to do the work, we'll learn even more. How do we feed that in a way that actually, let's do it once and let's do it right?
Yeah, think about that as the model of doing that, isn't there? Yeah. Martin, Charlie, Andy, and then what? Yeah, Martin.
Just a quick point, one to pick up on what Andy said and one directly to Dawn. I'll be quite frank, there was no silver bullet with comms. We did live radio, we did phone-ins, we did chat, we did all the district councils right down to local councils. Their existing comms team, so we accessed everybody else's comms, if that makes sense. Digital doesn't always work. We had some handmade signs in some places, quite literally, didn't we? People just drew them on a bit of A4 and put it on a bus stop to say there's a centre down the road. So the answer is all of the above, Dawn, and no complacency with that. We did live radio 2-3 hours every week, didn't we? Andy, you had the joys of doing it with me on a fairly regular basis and Prof Ward, didn't it? So, but actually that didn't penetrate as far as you might have thought it might have done. So even as good as that was, there was over 80,000 people listening to that on a weekly basis. But nonetheless, you just need to keep on top of it. I think the point I want to make to board a bit is outreach is why it worked. It's not the NHS sat behind somewhere that's not accessible. It's the NHS going out to the communities, and that's what made a difference. Now that's not inexpensive to do. It's actually quite costly, and there's a lot of resource required to do it. So we have to be sensible about that. And I think it's Maz's point that we need to work together to capitalise, because the mental health team might be gone out to talk to a community, but there's an opportunity there. We can send other messages, isn't it? Andy's team could be gone out to talk about other programs around Know Your Numbers, for example, but there's other opportunities to have a wider conversation. And I think that's why we need to come back to it again and again, to just synergize as much as we possibly can and take every opportunity and capitalise that way. That's just my general point. The last one's just a bit of a challenge because the national model this year doesn't lend itself very well. We don't have the resource to run the bus in quite the way that we had in the earlier waves of COVID vaccination. So that's going to be a real challenge for us because we won't be able to run the model in quite the same way. So it's just to kind of, we need to just cite that and make people aware of it, isn't it? But we'll wait and see. I was going to say a bit later on, but I won't because I checked the numbers last night. I think it's a positive message. I'll say it now because I know now that we've crossed 50,000 threshold. It was 48,900 yesterday. I'm sure in the time we were talking this morning, they will have now crossed the 50,000 threshold. So we're off to a good start, is all I wanted to say.
Excellent. Excellent. John, thank you.
Thanks. So just to add a couple of points on those raised. So Dawn, you make a really good point about measuring comms, and so we always do try and measure that. It's much easier clearly where it's direct and social media and so on. But I think Martin's point is really relevant there, that we know it's just a mixed bag and we will get everybody through a broad range. In terms of Maz's point that she raised about getting that, and Andy actually about getting that feedback back into the system, so not just NHS but across the county as a whole, there are a number of mechanisms, and I think what we could probably focus on is how we alter and boost those so that they're more effective. So from a comms point of view, we have twice weekly meetings within the NHS in terms of all of that information that's happening out in all of our providers, primary care and the ICB, coming back so that we share that. And engagement, our engagement leads in the NHS meet fortnightly. So exactly this sort of information that's being brought back from individual programmes are shared so that it can be cascaded back into organisations. From a much broader system perspective, I chair a quarterly network. So that is NHS, care, local authorities, we've got voluntary sector police, and that's extended actually out to business and commercial representatives. We've got tourism on there and so on. So communications and engagement leads from across those groups come together quarterly to do exactly this sort of discussion and workshop. So interestingly, at the moment, County News are doing a harvest with the public and asking directly the question, how do you want to be communicated with? So that's a discussion point that will come up into one of our future workshops because we can all benefit from that. I think a key point on that is I've described there the invitation in terms of membership. I haven't described the membership in terms of who comes to all of those meetings regularly. And so that would be my ask back in terms of how can we make sure that we really do pump that engine by getting the right people in the room with that responsibility then to cascade that down so that exactly the learnings that Steve has articulated really well there is then fed through each of those organisations effectively. But the mechanisms are there and we're getting better, but it can be.
Oh, thank you. Yes, I was going to address the issue around how we get that learning out there. And actually, it's really something Sandra and I
Yeah.
have been talking about, and indeed it sits very firmly under Sandra's lead as a director for health inequalities, and it's something that I am literally getting my public health team to look at now in terms of the links between some of these wider determinants of health, like socioeconomic deprivation or even culture and ethnicity, and the reasons that they produce inequalities in health, essentially, in the high level metrics such as life expectancy, but you can bring it down a level or two to health seeking behaviours. And what that could translate to, and I know John and Sandra and I, along with Derek and Debbie Barnes, have had discussions around how we work together even more closely as a system around the world of health inequalities, and we'll be putting some serious thought into that in order to do that, in order to serve the system with essentially a toolkit of here is how, if you've got a health service, you need to address some inequalities within. Here's how you understand what the inequalities are. So much like this work, it was not accessing it. I like the fact that you quoted, I'm not sure you used the metric, but the slope index of inequality, 98, 93, that's a 5% slope index of inequality. A toolkit of how to do that, how to assess that, and then also what do you actually do about it. And I think Sandra and I have been talking extensively about that, and that work is ongoing.
Excellent. Well, that was a really good discussion and presentation. Thank you, Steve, very much indeed, and loads of lessons there. Thank you. Shall we move on to the next item? Presumably we're going to be pretty quick with this item.
Yes, it is. And actually, I was going to ask if that's okay, Chair, that Andy could just talk to the paper. But yes, it's a very brief update for information.
And it's your show.
Apologies, colleagues. I always talk too much. So very quickly, then this will be very quick. We had an open invite, I think, came to John. The King's Funds will lead national work on health inclusion. These are the specific hardest to reach groups, as they would have been known in previous language, which is never that good a phrase, because to be honest, we're not often trying to reach them very clearly. But these are the groups who experience the worst health outcomes, typically homeless people, Roman gypsy travellers, maybe vulnerable migrants, sex workers, etc. We were successful in our expression of interest to join that work. And I would say quite clearly not because of our well-developed system-wide approach, and we do have lots of excellent work going on, a lot of it through the housing agenda, a lot of it through districts, in different places, a lot of it through, obviously, as we've heard, through the health side as well. And so our kind of pitch was, we want to know how to take the best national learning and skills and experience around this agenda and how you apply that to a rural coastal county with no one single centre of urban service delivery hub, because a lot of the best practice in this landscape tends to come from the major cities who have the highest number of homeless population, etc. So that work is starting. There are going to be a programme of action learning sets, and with some key third sector organisations. The first one was Friday, I believe, and we had Sean Johnson from the local authority. We had Becky McConville as well. I think Sandra, you managed to get into some of it as well. And we will feed into that, and the King's Fund will produce a report distilling the learning, the experience, and community principles. And I should say that we were the only local authority from the Midlands region successful in our expression of interest to join. So we were chosen ahead of many of the systems, which is encouraging, I think. So that work is ongoing, and no doubt we will monitor and feed that report back in when it's done.
Thank you very much, Nick. Keep posting. That's really good news. So we're ahead there quite rightly, so that's good. Excellent. Thank you. So that completes core purpose 1. Core purpose 2 is outcomes, and essentially it's where we handle performance. So over to you, Claire.
Yeah, thanks. For members of the public, I'm Claire Raybald, Director for Service Delivery for the ICB. We have covered some of these today, so given that we are overrunning, I won't do some of those in as much detail, but you've got the report in your pack. And as we talked about last time, and will continue to do so, as the Service Delivery Performance Committee establishes, we will refine that pack and we'll take on board the comments that Judy raised earlier. The areas of concern within there do all fall into the new categories of PA, B, C, D from the Secretary of State. So I have done my update in that context today. So We start off with the ambulance handovers then. These are often a barometer of pressure across the whole urgent and emergency care system, right from primary care right the way through to secondary care. So also a barometer of EMAS's own performance, but it is much wider than that. You can see from the data that our ambulance response times locally are not meeting the standard and not where we would expect them to be in terms of care for our patients. This is born out of a couple of things really. So there are delays in handing over at the front door of hospitals in Lincolnshire and out of Lincolnshire, particularly to the north of us, at North Lincolnshire and Gould for our patients that go there. And that the reason for that is because EDs are overcrowded and patients are waiting longer in EDs than they should, and you can see that borne out in the performance report. And that's largely as a result of poor flow within the hospital and lack of discharges. So we have on a daily basis far too many patients in our hospitals that actually are fit for discharge and our community hospitals that could be going either home without a package of care or could be going home with a package of care. And I'll come on to the care bit a little bit later, but that is a problem for us. On top of that, we are taking too many people to ED that really we could be managing in the community better. And I think we need to do a bit of a reset around all of our non-conveyance pathways. Yet now we're coming out of the worst of the COVID, but before we head into winter. So we know we've got a lot of services in the community and we've got a lot of access points, but some of that needs refocus for people, particularly within the care sector where there's a high turnover of staff in care homes, for example. We just need to remind them of what's available and how to access that. In terms of what we're doing about that, so we have an immediate handover policy for all category 1 calls, so those are the ones that should be answered within 7 minutes, and largely that isn't a problem for us in enacting, but we have had a couple of days recently where that has been an issue. For whatever reason, the escalation process hasn't worked, and we're doing learning to understand why that's the case. We have a handover trajectory plan to reduce 1 hour handover delays for later on this year at the end of November. We are off trajectory on that at the moment. So as a result of that, we've established an ambulance handover task and finish group to really get underneath that. So doing that, what happened yesterday, what's it looking like today, what are we going to do differently today and tomorrow to address that as best we can. And then a link to that, we talked about winter, which I'll come on to in a moment, but obviously the winter planning that we need to do needs to take into account that the people coming to hospital is going to get greater. So therefore, again, we need to be making best use of our non-conveyance pathways, but making sure that we're optimising our discharge, and I'll come on to the care bit of that in a moment. In terms of the Bs, the backlogs, so we've got some good news stories in there, and we've got some poor performance as well. So as you mentioned, 104 weeks last time, Andrew, is one that we won't go back on, and we continue to meet that trajectory. So we currently have 4 patients that breached that at the end of September, who do have a treatment date for October. They are breaches for what are called patient choice reasons or complexity, which are allowed or allowable because they're unavoidable really, either because the patients made that choice or because their pathway is so complex it requires a little bit longer to complete. But we don't have any for capacity reasons, which is the target that we were set in June, and we continue to meet that. We have 24 across other providers, so that's across 6 different counties outside of Lincolnshire, and that's an invalidated number as of yesterday. And again, they are a mixture of patient choice and complexity. There are some capacity ones in there where we are already working with those systems, and the region already is to reduce those. So we continue to work closely with those systems to get that reduced for our patients, and they're man-marked in the same way the Lincolnshire patients are from our teams. In terms of 78 weeks, as we said, the pledge is to reduce that by March 23. We have a trajectory in place for that, and we're actually we're doing really well. We're ahead of our trajectory on that at the moment, which is what we want to do, because we know maintaining elective care through winter is always a challenge, but this year more so than any other. Outpatient activity is the biggest challenge within that. So people tend to focus a lot on people that need operations. That's 10% of our waiting list, to put it into context. So 90% of our waiting list is those people that are needing to see an outpatient appointment. And outpatients was the thing that got stood down the fastest, and always does when we're under pressure. It's the first thing that stops to focus on emergency care pressure. So in terms of the improvement programmes in outpatients, they have been the ones that have been delayed the most. They're also been most adversely affected by the IPC guidance when we brought services back on, social distancing. They're high turnover clinics, aren't they? So if you've got to do those with social distancing, it's been quite difficult, but they have got some really good innovative solutions that they're looking forward with those at the moment. Greater use of advice and guidance, patient initiated follow-ups, and you'll see that in the report. In terms of cancer, that's one where where obviously we've talked about already today. Significant focus is on the colorectal cancer position. So it's currently 60% of our backlog. So it's significant. The numbers have increased since what's in the pack. So we got to a position, mainly due to the August holiday period, really, of going over the 600 mark in terms of waiting, which really wasn't the position we wanted to be in. So as a result of that, we've instigated daily colorectal recovery meetings. They're led by the Chief Operating Officer of the Acute Trust. And that's now seeing that come down to around the sort of just over 500 mark. So we are making progress, but we're seeing high levels of referrals into these services. So we're seeing typically 170 go in each week. We don't have the capacity to see 170 every week, plus deal with the backlog. So you can see the challenge that we're facing. So there's a whole range of actions that are outlined in the pack there about what we're doing. So that's the FIT pathway that we're doing with primary care. So that's making sure we're able to stratify patients when they come in, so we can make the right clinical decision about where we need to see them. Much more capacity into clinical reviews, but we're pulling this capacity from other parts of the pathway. So it's a real challenge to balance, but Simon's doing a really good work on that, and we are seeing that recovery start to come down, which is really good. We are still keeping the focus on the other tumour sites as well, because whilst it's 60%, clearly we have got 40% in the other areas. So Cancer Board's meeting as we speak at the moment, so they'll be doing another further deep dive on that today. So it's a real challenge. It's going to take us a bit of time to get through, but we are getting there. We've had great support from the clinical directorate and from Sunil as the medical director and clinical leads in the ICB. So I see that that's we've got the green shoots are going in the right direction, and we still remain in tier 2, which is the oversight nationally. Tier 1 means John has to join us on all the meetings that we have. So we have a weekly meeting with our regional colleagues at the moment about this, so you can imagine the work that goes on behind. So that's all I'll say about cancer at the moment. Just in terms of diagnostics, just wanted to make you aware, it's a bit of a good news story. So we've got the Grantham Community Diagnostics Centre, and that's seen 21,000 appointments since it opened in April, 21,000 this year. So that's huge in terms of that community diagnostic capacity that we wouldn't have had. We do still have challenges in some parts of our diagnostic, and the fire at Lincoln earlier on this year and other things haven't helped, but we're in a better position than most. In terms of primary care backlog, we've talked about this earlier, so I won't go into it in too much detail, but in terms of pre-pandemic levels, actually we are back to those in terms of primary care access. We're the 3rd highest in the region as well for that access, so that's actually really positive. So just wanted to share that with you. In terms of mental health, we talked about this last time about early intervention psychosis. Sarah updated on the plans that we're doing, so I won't go through that in detail, but that is starting to show recovery signs now. Sarah might want to add a bit more. So that again is, that was a challenging position, you'll know, from the recruitment and being able to move that on. And Sarah outlined last week, we're not expecting to see that improvement for some time, but actually we have made significant progress. Don't know if you want to come in at that point, Sarah, and we carry on.
Yeah, we've worked really closely together, and we've actually been able to achieve the target in August, so it's back on track.
fantastic because as we said last month, we were thinking that was going to be more towards the end of the year. Just staying with mental health then, so out of area placements, I talked about this last time, we've done really well as a system on that, and actually just been noted in a bulletin that's gone out nationally as Lincolnshire being best practice for out of area placements. So brilliant work from Sarah's team and also the ICB team on that. So yeah, really good good news on performance. Children and young people, Martin might say about this a bit more in his update as well, but a continued focus. We are seeing a real rise in demand for those services as we come out of the pandemic. So again, that is a bit of a challenge for us. In terms of care, so we know, we've talked about it already, having robust social care is a key to unlocking our discharge. It's not the only ingredient, but it is a key one. We know that our providers are really struggling to recruit in Lincolnshire, and it's really difficult to get that workforce. We're up against the challenge of other provision and other sectors that are also recruiting, but there is a significant amount of ongoing joint work with the local authority, our health providers and the provider collaborative to improve the discharge position, and that is bearing green shoots, and we look forward to hearing a bit more about this winter discharge fund as well, and see if that can help us even further. And then just finally then on the doctors and dentists bit, so we've talked about dentists already quite a lot, but access to GP data is in the pack. We've put a bit more in there now for you. We do benchmark really well, and if you can see, the face-to-face is already above pandemic levels, which is often something that gets cited as an issue. You know, nearly 50% of people are seen on the same day, and that also benchmarks really well nationally. And our extended access has really good availability, but it is only 74% filled. So, you know, those appointments aren't there, but they're not always being used by members of the public. So the standard is 80%, so we're fairly close, but some really good work, as you've heard already today. That's all I was going to say on the performance report, Andrew. Happy to take any questions, and we will tailor it a little bit more, particularly as Dawn's committee gets more established, and the reporting up here will be a bit more succinct, I think. I know there's a lot of pages there.
Thank you very much. Please.
Two things. In terms of the backlog, how confident are we that the numbers are accurate and people haven't decided they don't want their outpatient appointment anymore or died or whatever?
They're as accurate as they can be. So we've been doing quite a lot of work with the Elective Activity Coordination Hub, also called the EACH in Lincolnshire. So they've been taking some of the really big specialties and they've been ringing in patients that are on the waiting list. We have seen in some specialties quite a big drop off actually of patients that have either it's got better, you don't need to be seen, or they've sought care elsewhere, or you know, other reasons that they don't want it anymore, including what you've mentioned. So they are doing that for some of the big specialties, and we're working our way through those. So we're working with the most challenged specialties first, because they're the ones that we really need to get a grip of, and that might cause us a problem if we don't. For some specialties, you do see more of that. So dermatology is one where quite often people say now they don't need to be seen anymore. Whereas there are other specialties where actually the majority of them did need to be seen. So, but we could share that at our next meeting.
It's quite important. Obviously, we're talking about backlogs.
It's really interesting.
Make sure that they're accurate.
Yeah, absolutely.
And my second point was, we talked a little bit about it at the committee around having the little graphs are really useful, and obviously there's a target and that's where we are, but I think a kind of trajectory as to how we think we're going to get to where we're going to get to. It might we have a target, it might not, but a kind of a plan, you know, what is realistic. Let's be realistic with this. Where are we going to really go? How are we going to get there? And how long is it going to take us? Just to give us a sense of really how well we're doing against our people.
Yeah, when we bring through the Service Delivery Performance Committee, we've got those people booked in, haven't we? So when we do the first one, we'll bring all of that information to the committee as well, and then we can report upwards. So
thank you. Just a couple of points. So thank you for that, Claire, really helpful. Just to say, from a community perspective, with waiting lists, some waiting lists we are able to really be managing really positively, but again, like with every parts of the health and care at the moment, we're seeing demand. So particularly in young people, speech and language, and adult speech and language, you know, we have people that we weren't seeing in during COVID, but also coming out of COVID, a lot more referrals, and I think that's the bit that we just need to absolutely understand. But what we are doing is we've got risk assessments, we're making sure that people are fit to wait, etc., and on our waiting list. The other thing just to link into with Claire, particularly around the discharge and flow work. So there's twofold really. There's an element of workforce, and yes, there's a competition outside of the health and care sector at the moment that is a real competitive for us. But also there's cultural change. So the work that ULHT is doing internally is a huge cultural piece of work, particularly around flow. But as Claire says, we are seeing green shoots. And from a CEO perspective, and with senior chief operating officers, we're meeting on a weekly basis to really drive and oversee that area.
Thank you very much indeed. Thank you.
Just to add to the we is all for chief executives. We meet every Wednesday afternoon. We now split our meeting into part 1 and part 2. And part 1 is a total focus on discharge and flow, on winter, on ambulance handovers, all of those bits. And Claire and respective colleagues from across the trust as well are in attendance for that. So just to really reassure the board, all 4 chief executives are over it, sort of that level of scrutiny. Thank you, Andrew.
So I think, I mean, our perspective, there's loads of great things. The danger points are ambulance transfers, and we need to gradually work because obviously the colorectal cancer is just to confirm, all our cancer screening programs are back up and running.
They are, yeah, they're all back up and running. For breast screening, we do have quite a significant backlog, so that's commissioned by NHS Lincolnshire, but we're working closely with them because it's about how you balance, isn't it, the breast screening work and the 2-week wait work, which is the same workforce with both. So we are working really closely with region and with public health on that as well. So that's the one that's probably the one I would say is a concern. The rest of
Okay, thank you very much indeed for that report. It's a snapshot of where we are. So Martin, I'm going to turn to you for the quality report. You'll probably notice we're in the coffee break at the moment. My fault. Sorry about that. So much to discuss here. So we'll take a short coffee break. About 5-10 minutes. Is that all right?
Yeah, that's fine, Chair. Thank you. And I suppose I want to focus on the kind of patient safety and quality elements of the report. So I won't cover off the performance elements because actually, to be fair, Claire's done a very elegant job with that. So I'll stay clear of that. I do like to open with some areas of improvement and areas of deterioration. And we kind of heard the deterioration. So I'm not going to go over that again because we've covered that ground. But I am pleased to say we've seen continued progress with the LD health checks. They remain on target. So I'm really pleased. We've done actually more than we've done this time last year. So it feels like we're on track to get to that target. So I'm really pleased to say that. We have actually seen an improvement since I last spoke and board about ambulance CAT 1 and CAT 2. So although we're seeing real challenges when people get into hospital around the handover delays, but the community response time has slightly improved. But nonetheless, there's a way to go with that. But I think it's important to cite areas of improvement. The deterioration I was going to cite is the same, particularly around the 12-hour waits, long waits in A&E, and some of our challenge around ambulance handover. So I won't go back to that again. I did want to cite some challenge we've got, and maybe I'll give Sarah a chance to comment on that in a minute, but we still have significant challenge, or we're doing reasonably well around SMI, severe mental illness and health checks. Some of the methodology that we've applied around the system, around dealing with the LD health checks, we want to sprinkle that approach onto severe mental illness. So we're confident we've got good, robust plans in place, but we will see some good improvement there. But the target's 60%, and we're around 47, 45% at the moment. So we've got a way to go with that, but it is better than it was last year. And actually, we benchmark really well in the East Midlands. We're doing better than most of the comparable ICBs. So it's a mixed bag, but the challenge is we've got a bit of opportunity there to do better from a wider health protection point of view.
No, just to reiterate everything that Martin said, and there is an element of under-reporting as well. I think, you know, we face it a lot, I think, in the health system, is making sure that we're actually capturing where we have done health checks, making sure we've got robust data. So it is an under-reported position at the minute, and we're looking at getting a piece of software that can help with that. So we'll be able to get more robust information reporting by the end of the calendar year.
Sorry.
Okay, no, that's fine, that's good. And Claire already mentioned this, but I was going to cite, particularly for a patient kind of outcome point of view, to see the improvements around the EIP pathways is really heartening to hear from a very challenged place a couple of months ago. So great to see that's going in the right direction. That's probably all I was going to say on mental health. I wanted to give a very brief overview where we are with the wider LD and sort of autism, and particularly around transforming care. I'm pleased to say for couple of months since I last reported, but we're maintaining the same levels, so that's really good. We're pretty much so, we're probably about 3 patients off track. I'm not unduly overly worried about that, but that's around our ambition to reduce those inpatient numbers. But I think it's important to give updates regularly at board and give assurance that that's moving in the right direction. So moving on, I'll do SIs and never events. Never events are events that we don't want to happen. They're called never events because they should just that never happen. Unfortunately, we've had one, a wrong site surgery. I'm not overly worried, but they are quite rare. We have probably about 5 to 6 a year. You want to have 0. Let's be really clear about that. There isn't a target. The target is an end game, none. But again, not overly worried about that. It happened at ULHT. By way of wider SI serious incidents, we've had 39, which is actually a reduction since the last time I spoke. We had 50 previously. But again, it's about the average runway we expect to see, and no significant themes in those serious incidents that I want to flag today. They are where you normally expect them to be. I am pleased to say with the mortality metrics around the shimmy and the HSMO, we're all broadly speaking within metric, within kind of trend or range you'd expect them to see them at. So that's good, that's significant. We've seen that consistency from what I told you about 2 months ago, but previously 6 months ago, we had a number of outliers there. So I'm really pleased to say that that's moving in the right direction. We still have a very focused conversation with NWAC down towards the south, and we do that in partnership with our colleagues in Cambridgeshire and Peachford PCT. So ICB, even if I can get my acronyms out right today, but never mind. But we have robust recovery plans in place there, but we still have some challenge around that to really understand. To be really kind of succinct about that, is it a coding issue or is it a clinical issue? We're pretty confident it probably is a coding issue, but we're working close with that trust to bring about that recovery. I did want to bring back today just about the significance of launching the COVID vaccination programme. The autumn booster is off to a great start. I gave the big reveal of the current figures, which I'm really pleased. That's very good to where we expect it to be. Just to remind people, it's everybody over the age of 50, everybody who's pregnant, and all the at-risk groups over the age of 5 and under the age of 50, plus including obviously the over 50s. They're the people in the clinical vulnerabilities, or people who might be immunocompromised, or people with long-term health conditions. So it's a pretty significant campaign, and the ambition is quite high. Lincolnshire were performing in the high 80s or low 90s last year by way of our VAC programme. Our ambition is the same. Our ambition is to do even better than what we did if we can. But I guess the challenge will be is will uptake be at the same volume we expected it to see so far? And I'm really pleased to say that, because only last week we've had a conversation about standing up additional capacity with the drive-through, where we felt initially we might not need it because we weren't as convinced uptake would be quite as rapid or as interested right at the start of the programme. So I'll keep a keen eye on that. I think we'll keep reporting on a regular basis, but like I said, it's off to a good start. So nothing significant to report there other than it's a good news story so far. Claire mentioned this, but I think it's really important just to emphasize the continued good performance around elective recovery and diagnostics. If you look in the report, it's a full sheet of green, which is very rare we're at that point. So I just want to congratulate all colleagues who are involved with those diagnostics, because it made a big difference in our system. I'll probably over to the second part of the report, care home and quality. You will see, and I don't necessarily major on this too much, but I thought I would today just pull it out a little bit. This is about the work we do jointly with our local authority colleagues, particularly about care homes and nursing homes. You'll see there's been by way of, we've had a reduction in the number of suspensions. It's gone from 5 to 2, which is a good news story, but we have seen an increase in the number of what we call default notices. So that's where there's a worry or concern about a specific care home and nursing home. That's gone from 10 to 14. And again, it's kind of a mixed bag around the CQC ratings. We went from five less good, if that makes sense, since the last time I spoke. And you'll see that there's 3 more care homes that requires improvement from a CQC outcome point of view. I wanted to assure that we work very closely with the local authority, equivalent quality teams. Each one of those care homes will have a recovery plan and an agreed set of actions to get them to where they need to be. I'll put it in proportions, a bit like John's point earlier with primary care. We have in excess of 250 care homes in Lincolnshire, so the vast majority are doing quite well for us. But nonetheless, there is a significant challenge with a smaller number of care homes. I have nothing to report, which I won't, by way of exception in respect to Send or Ockington, so I won't cover that off. The last couple of bits of the report will focus on primary care quality. I did think it was important to bring it up today. You'll see the continued sustained performance, particularly around face-to-face appointments in primary care. So you'll see that's above national average, and we're doing quite well with that. So I'm really pleased to say that. No significant change in the wider over CQC ratings. You'll see by way of requires improvement, you'll see it's Lakeside, Morisco, Spalding and Braunston. So that is as it was when I reported it previously. Hereward has had a CQC inspection since the last time I updated in July, and they've maintained their good status. So it's really important that we acknowledge that. So really pleased to see that. By way of where we got challenge around requires improvement, we still have and continue to do, obviously, what I would describe as our enhanced support plan with those 4 ORI practices. I'm pleased to say they're moving in the right direction, but we have about another 3 to 6 month window before the CQC will have gone around to go back to those practices, and hopefully we'll get them from ORI into good. So that's where the ambition is with it. And that's it. It's pretty lightningly quick, Andrew, but I just wanted to give a high level overview.
Thank you, Martin. First of all, Jerry, would you like to come in with a comment? I think you wanted to make that share.
Thank you very much indeed, Andrew. Martin won't be at all surprised with a comment I'll make, just really for the benefit of the board and in particular future meetings of the Quality Committee. I hope you can hear me okay. I've got a little bit of static feedback at my end. Just very briefly, 2 things. Firstly, never events, as Martin says, they should be never. And the previous CCG Quality Committee did note a trend that wrong site surgery was not uncommon at ULHT. And I say that carefully, but at the same time, we would, I think, be concerned to continue to see wrong site surgery taking place, given that I think a number of the ones that have been noted in the last year are wrong site surgeries. And secondly, and finally, the mortality shimmy at Peterborough City Hospital has been consistently high for over 2 years. And I think, Martin, it would be fair to say we've never got to the bottom of understanding what is happening at Peterborough City Hospital, in which is driving their shimmy to be significantly higher than it should be. And I know Martin and colleagues have been doing some very good work in the quality reviews with NWAFT, and clearly we are partly dependent on the work of Cambridgeshire in this regard. But for the benefit of the board, we've never quite got to the bottom of understanding what is it at Peterborough City Hospital in particular, which is driving their consistently higher shimmy rate. And it's masked by good shimmy at Hinchinbrook. So I just wanted to just really put that on the table for colleagues to understand the background of the CCG work that's been taking place on this over the last couple of years, to some extent with no great success, but nonetheless for colleagues to be aware of it. So thank you, Andrew.
Thank you. Right, okay, perhaps we need to look at that outside further. I mean, we could formally write Peterborough City Hospital with our concerns, but I couldn't get a written response for the answer for the questions I was posing. But I don't know, that may have already been done. I don't. John.
Yeah, I wanted to raise the 2 points that Jerry raised actually. On never events, we should be worried actually if it isn't zero, and it has, to my recollection, never been zero. So I think that there's something perhaps with Sunil, Martin, just in terms of getting some greater degree of understanding and assurance about that. I know there's some significant issues around it, but wrong site surgery is something that I think has been a feature, as Jerry's highlighted. So I think for the quality committee, there's a bit more to be done around that, if you don't mind me saying so. And again on the shimmy at Peterborough City Hospital, I know that Sunil has started to open up a relationship both with his colleague in Cambridgeshire and Peterborough ICB, and also there is a new medical director at Peterborough or NWAP as well. So I think there's a specific ask for Sunil with our support just to chase through on that point a bit more. But I know from discussions with Martin that it has been really difficult just to get behind that rate, as Jerry's indicated. But I don't think we should give up on trying to get the degree of understanding of that. But we require over 150,000 of our Lincolnshire population look to Peterborough City Hospital as their acute provider. So this is significant.
Yeah. Okay. Pete, Martin, and we'll conclude.
Yeah. Just a quick question. So looking at the serious incidences, and ULHT for slip, trips and falls and Peterborough for pressure ulcers stand out compared to the other kind of levels of incidents they have in it and against other organisations, which is normally an indication of numbers of staff, nurse and staff on the wards and kind of care for the patients that they can have. Is there anything specifically we should be concerned with that level, and is there any work taking place? I'm just thinking if we go into a very busy winter period, pressure ulcers, obviously a big concern, aren't they, in patients. Is there any work taking place to address that, or is there any kind of significant saying?
Yeah, if I pick the kind of size, there's nothing at the point of where we think it's above trend, Pete. So yeah, to answer that, not a major concern, but there is a specific piece of work that actually we're doing jointly with LCHS from the system quality group. So Susan Almer is supporting with, Nancy will be very familiar with the work, but her and Vanessa are leading a focused piece of work, particularly on pressure sores. So that's an area of where you've got a keen eye. That is without a doubt hands and arms further along by the number of if you like, pressure sores related sort of SI incidents. Some of that is national reporting criteria and how you've got to report them. But equally, there's opportunities because most of those issues will have happened in the community before someone came in to hospital in reality. So there's opportunities to do that different. LCHS often pick them up post-admission or a little bit later on. So something about the work we do right down to our domiciliary and home care providers about the care and support that they're offering around that. But to answer the question, there's a very specific train of work that's been done around that. That's feeding back to the system quality groups. That's where that's being led and held. That's probably all I would want to say on that. Just to pick up on John's point that Sunil spoke to me just before he went to leave. So we've got a date penciled in the diary with the new medical director for NWAP, Jerry. So Chair, by way of formal escalation, they are a formal escalation with NHSE. So myself and Sunil joined the previous meeting. So that very much so has been raised, if that makes sense, at the very highest level of escalation to do a deep dive behind that. I've joined both those meetings in partnership with both the regional team and the Cambridge and Peterborough ICB lead. So I deal with Carol Anderson, who's my equivalent as Director of Nursing in Cambridge and Peterborough on a fairly regular basis. So we've got follow-up meetings scheduled for that. But I think the challenge is valid. We need to just really understand what our collective efforts are with that. I'll report back as hopefully we'll see progress. But it is a challenged area for us, and we're not seeing the progress we would want to see by now.
Quickly, residential homes and nursing homes. A lot of these homes haven't been CQC rated for quite a long while. And I am seeing a lot of, certainly in the last few weeks, complaints about homes. It really does concern me that we've had COVID, we haven't been in to look at them. A lot of these homes are using agency staff, and some of the worries that I have, that I know Alina and I are sharing at the moment, we have got some real concerns, and about some of them, there will be a number that aren't going to carry on because they just can't fit the purpose. So it is a worry.
Okay, so we from this, I think there are three things from this report. I mean, to pick from the action log and through to the quality committee of the ICB, which are the shilly issue, the never events issue in the care homes. Which is on the never event. I mean, there are never events and never events, not really. We never wanted another event, but on the one hand, we want the culture of people report. But wrong side surgery is the serious end of it. So we need to do investigation. We'll have those three specific points in the report to look at. Okay, we've done this one. Sorry, Nancy.
Sorry, just very quickly. I know when we go into care homes, because obviously we're a regular attender, if there are things we will flag them through our
reporting. I'm just wondering if there's triangulation of if there's stuff that we're reporting up and in from a quality, but actually there's anecdotal. How do we collate that to actually give us that more? That's the whole thing about quality, isn't it? It's the eyes and ears of the whole picture. So maybe that's just something to think about as well, Martin.
Yeah, no, I get it, Mars, but that happens at the system quality, and where did the local authority leads give us the report and intelligence?
Yeah, I understand that. It's about I mean, we've just got behind. That is the problem with COVID, and there's a lot of homes out there that are running.
Okay.
Yeah.
Okay, well, let's get some facts on that. Etc. etc.
Yeah, just quickly, the health protection team from the ICB are starting to do practice visits, which are almost like some mini CQC type visits. I just wonder if local authority do similar visits across their care homes. Yeah.
The full activity of CQC and the local authority is back to normal as to what it would be. But I fully accept, Wendy, there would have been a pause in those inspections during the depth of COVID. So it'll take a while to get around that suite.
And it's when people are looking for homes. I mean, I've got somebody who's been looking, this lady's been in two now and she's moving again because the care is just not up to standard. And I just think that is just terrible. If you're choosing a home for your relative, it doesn't matter if it's a relative or one of my residents, you've got to be able to read these things and yeah, that's good, send them in, but it's a different thing when you get there, isn't it?
Some facts on that. Thank you very much indeed. Right. Okay, but a pause here for a break. I'm afraid it's just 5 minutes. Could you grab a copy? We'll probably start. We will catch up. Thank you very much indeed. We're back on, so we're going to 6.1, the finance report.
So the report is at month 5, it was to August, it presents the cumulative actual position as at month 5 and a forecast for the end of the financial year for both the ICB and for the Lincolnshire integrated care system. Positively, from the forecast position, we are forecasting to be on plan, break-even position for the system by the end of the year. However, we are reporting on that a risk of 27.3 million unidentified. So quite significant risk in that forecast. That's showing already in the year-to-date position, whereby we had a plan as a system of a 1.4 million deficit, and we've reported 10.27, which is 8.79 million deficit to plan. This is mainly on 4 areas. So one is under delivery of efficiency and waste reduction. Second is unplanned costs associated with COVID. So our plan that we set at the beginning of the year was based on very low numbers in the acute hospital, ULHT, and as we've already heard today, those numbers are really, really growing. So to enable us to take out some of them beds and to reduce some of them costs, that will help us get back to our plan. But what we're hearing at the minute is they're going in the other direction. Higher than planned level of open beds, also linked to COVID, and higher than planned staff costs driven by bank and agency volume, and also the price of some of them. Positively, we are delivering well on efficiency, although we are a little bit behind where we should be. And our efficiency plan, when we put it in, did have 19.9 million unidentified, and we are still striving to find opportunities to bridge that gap. We are looking to enter into further programmes. The phase 1 programmes that we've implemented so far are the care close to home, MSK and prescribing initiatives, and the spring phase for these were completed in October 2021. We're now about to start the phase 2 initiatives, being frailty and same day emergency care. So hopefully they will help bridge some of the risk that we have highlighted in the report. Further actions that we are taking to keep an eye on that gap that we're seeing year to date is the continuation of the investment panel and double lock. So this means that anything over 250,000 not only goes through the first phase, but goes to a second panel. The first panel took place in August, and a further 2 are planned to kind of confirm and challenge against them investments and their delivery. Still greater focus on controls to reduce bank and agency. We are looking to accelerate delivery through risk and gain share that we've I know that Matt's brought to the meeting previously. A commitment to take a long-term view. So financial and efficiency at the moment, we tend to just report to the end of the year. What we're looking to do is start to bring in 18-month and 24-month forecasts on them, so we can start to see where we think we're going to be on a more longer-term view and not just looking to the end of this financial year. We really want to look at that in-month position, so striving as a system to have an in-month break-even position. So not just look at what we've done year to date, but look at what actually happened in that month. What do we plan to spend? What do we actually spend? And did that come in on plan? We want to ensure accelerated processes for implementation and transformation. So when we do find schemes that we want to take forward, we need to make sure that across the system we've got ways of taking them forward quickly and making sure that that transformation can occur as soon as it's identified. And also across the 3 providers and the ICB, we're having an internal audit review of system financial governance, which was a checklist that was published by the HFMA, and that's going to be audited by Grant Thornton for all the providers and the ICB. That's planned for late October. I'll pause there if anybody has any questions.
Okay. Any other questions? Have you finished your report there, basically? Yes.
Yeah.
Thank you very much. you.
Yeah, I'm happy. Yeah.
John, okay, sorry. I thought you were pointing at me.
No.
John.
Emma, thanks for the report, and Andrew, you recall, the discussion about the finances at the quarterly system review meeting. But from chief executive perspective, what I see is a lot of really good work happening in this space, but very clearly alongside that we've got a financial challenge in year. I thought that we might have had a harder time at that meeting than we did have, and I don't want us to think that just because we didn't, we haven't got a really tricky set of financial circumstances here. As Emma's highlighted, there's good work on efficiency, but it's not where we want it to be. The local and agency side of the house continues to be a real worry. Matt and I have had a series of conversations with Andrew Morgan and Paul Matthew at ULHT, particularly around that and how that's the work that they're doing in relation to that. And we continue to have unidentified savings, as Emma's sort of highlighted, and we've got programs in place or approaches in place to try to get identified savings and then deliver those. I just think, just to note, Andrew, the serious nature of the position that we're in. As I look across the region and I see other people's positions, then clearly there are some even more severe concerns elsewhere. But as I think I said already this morning, I don't think we could take any comfort from that, because not only are we where we need and want to be, but we're some way off being in that position. And I'm sure that our Finance Committee will continue to be extremely active and diligent over this as well. Thank you, Andrew.
Julie.
As chair of the Finance and Performance Committee, I can assure you we were certainly concerned about the level of risk in these numbers. And as it's been said, 57.3, and with hopefully mitigation of 30, that still leaves us quite a significant risk for the current year. On top of that, we have to deliver over a 2-year period financial balance. If we don't, we've got another 22.7 million risk that comes in and hits us. So they are big numbers, and halfway through the year, there's a lot to do. And everybody's focused on it, but there is a big challenge, I think, to deliver. And it's hence one of the reasons for looking at the efficiency programme and the CIP programme, not on a 12-month basis, but on a rolling 18, 24-month basis, and actually having some 5-year schemes that look longer, because some of the big schemes take a long time to deliver. So I think we've got to stop the short term. I mean, we've got to deliver on a short term, but we've got to move ourselves to looking medium and long term to get the really big savings that we need to do. So again, I think that's what from a Finance and Performance Committee we're trying to push towards.
Thank you. If there's no more comments, Dawn.
Yeah, I just want to pick up on that, because the one thing I highlighted is that we have the efficiencies and we have the risks associated in the numbers. A lot of the numbers are non-recurrent, and I wondered if there was enough resource looking at that kind of stuff. So if you didn't look at headspace to sort of just, this is, we need to plan it longer term, but actually need resource.
I think that has been discussed.
Scheme for this year, sort of thing.
Yeah, that's been discussed, and I think there is a discussion on resourcing for all of this.
So if there's no more.
I was just going to come back on that point. I think that's why it's really important why we're starting to look at the in-month position and be really clear on what the underlying win rate is that we've got within the system. So yes, we've got a lot of non-recurrent efficiencies this year that are supporting that reported position, but we can have a real keen eye going forward on, so what are we really delivering in months on a recurrent basis, and therefore what does that mean in the longer 18, 20, 24 months.
Okay, if there's no more comments, thank you very much indeed, everybody. I think this is a worrying position, and it's only our second meeting since we started in July in terms of business meeting. but I think it's one area where it's not perhaps surprising that the region isn't coming in and we're jumping to the region, because this is the ICB's board's responsibility now, not the region. It's ours, it's the first one. And second is particularly interested in what other systems are. It's interesting, but it's about our own system. So let's not take it on this particular issue. Let's not take conflict out of this part. We need to get a plan, which I'm sure we've got coming to sort this out. There's this huge elements of risk in this unidentified and are backloaded. So we're going to get ourselves into a position by April 23 that is strong now, that we can prosecute through those things. So, serious position. I think the Finance Committee have a really good look at it. Clearly, I'd like at the next development session to set aside an hour, that's all right, to have a real look at this financial position and what the plan is. Because if we slip into and all the rest of it, I don't know what I want to say, but still got to go forward. So we're going to be, more. So this is a problem that we need to solve it in 6 months. 2 years, you should say. We do need to solve it. There's too much risk in this plan. It's too complicated. Too bad. The efficiency kind of stuff. So we'll have a look at it. But thanks. Notwithstanding that, I appreciate that loads of work is going on. So to the committee and then to the development session for an hour where we'll really understand this. What plan is. So all members of the board get that. I think you'll see the region backing off as there was. Okay, thank you. Cost of living, John. So.
Yes, thank you, colleagues. So you will be aware that the rising cost of fuel, food and other essentials are combining with existing disadvantages and vulnerability across the communities to put many households at greater risk of immediate hardship. And with that, the reduced opportunity and well-being. If you then layer on in terms of vulnerability and particularly members of our communities that have long-standing health issues or other social challenges, that increases the significant risk for those people living in our communities. And if you then further layer on the anticipated COVID, flu and just general sort of like winter illnesses that affect people, there has been an identified recognition of the challenges that will face for people living in our communities. The integrated care system has agreed that we need to respond to that by making sure that we're coordinating, communicating, acting where we can and influencing to make best use of the opportunities that are out there to support individuals. So this isn't necessarily about the ICB paying individuals or providing financial support, but it is about making sure that people are aware of the opportunities that are out there to support them. And there is significant work going on across all elements of the various sectors to maximise opportunities through grants, making sure that information is out there so people know where to go for support. As part of the Better Lives Lincolnshire leadership team have commissioned a task force. Now the task force will meet for 3 months and the primary aim of that is to make sure that we bring together all of those different initiatives in a, as I say, a coordinated way so that the information is accessible not just to members of the public but also to our staff. Both because some of them will be affected by the issues, but also that they will be directly in contact with people who are most vulnerable.
We've had 2 meetings. The meetings are led by district council colleagues in partnership with the third sector, and already we can see the breadth of interventions that are going on across the county, and bringing that together. So I'm pointing to Wendy, but through the county website, there is already a link on there to some really important information. And from a health perspective, what we will be doing is making sure that that information is communicated as far as possible. And Charlie and I have had the conversation about how do we make sure that this reaches frontline staff so that they can have the conversation with patients directly. I don't think there's anything much more to say, except it feels like a very vibrant space in terms of the cohesion and shared objective to really put the mechanisms in place to support local people.
Thank you. Thanks, Sarah. Anybody want to make any comments on this?
Just a very quick
one. Yes.
Just very quickly, you've noted a lot of organisations you're working with, and I've brought this up before, but are you working with local housing associations as well? There's so much data on the residents now with this massive data resident engagement programme they have to have.
Yes. There is the stakeholders and partners have got connections in with all of that, but yes,
because they can do also a lot on employment, health, and financial support and all that kind of stuff.
Yes, yeah, and just as a side issue, I think going back to the discussion we had about inclusion earlier on, actually, as you said, it's opened up my eyes to the richness of information that I think will help us understand our populations and the particular areas of challenge for them. So yes,
there's so much learning through COVID actually. Yes. When people were locked down, actually it's really kind of helpful.
Okay. Thank you very much indeed. So we note the establishment of the task force and support the actions confirmed. Presumably get a read back in due course.
Yes.
Thank you very much indeed. Lovely. Okay, on to governance, item 8. Number 1, the MOU. Pete.
Yeah, this is a brief paper outlining the kind of key features of the memorandum of understanding that the ICB has signed with NHS England. It's developed in conjunction with NHS England regional colleagues, and it's gone through the Lincolnshire Leadership Group for approval before going into the regional team. Had to be signed earlier in the month once NHS England approved it, which has happened, and John has signed it really. So it's here for noting, and it should say it's a MOU that's in place with every ICB across every ICB across the country has an MOU in place with NHS England really. The key principles in it really, it underlines how NHS England will work with the ICB and how that kind of the governance arranged around that works. It also identifies kind of the governance within the system, so it's clear to NHS England how our oversight takes place, and also how we work with partners, both within NHS England and with our trust within the system going forward, and also how kind of issues will be addressed. And the key difference here, MOUs have been in place with NHS system for about 2-3 years now with NHS England and improvement before the change in July. Key changes with this one is it's not with the system, it's with the ICB. So previously it wasn't with the CCG, it was with the STP that described back then. So this is with the ICB as an organisation, and it changes the relationship somewhat in terms of NHS England now expects the ICB to ensure performance oversight and coordination for improvement activities within the system itself, and that oversight with providers. And I think the fact we we've set up our committee structure enables that to happen by having joint committees to have that oversight and improvement discussions take place. If NHS England have concerns about service delivery or performance or any specific issue, the MOU described that they would contact the ICB as a first point of call, and the ICB would then pick up that issue within the local system. So that is different. Not happening just yet. I think there are instances where that doesn't get followed, but I'm sure that's the principle of travel going forward. And then finally, it just also articulates the fact that because we're a segment 4 system, we have the QSRMs will continue to take place, but they take place anyway. But also, NHS England will join the Lincolnshire Leadership Group meeting, which takes place tomorrow. They have a representative there. Then also on the Provider Collaborative, which have the Care Collaborative Board, and they also will attend ICB execs once a month. That's the group case, but just to get their kind of sense on the work taking place in the system, really. So it's not a new bit, but it does kind of change the relationship somewhat. But I think it's going to take time to embed in, and with NHS England changing their operational model as well, we have to take note of that over the next 18 months. If that changes, this will change also. Happy to take any questions.
Not a question, just a comment, just to say that we have NHSE representation on the Mental Health and Disability and Autism Alliance as well, so there's that cross fertilisation.
I think the key issue is the spirit in which this MPE works. The ICB standing organisations, you know, I know in some parts of the country this will be very full. Best of it. I don't think that's the spirit that's really good. So it's excellent partnership arrangements. It's how they take those. So we talked about this outside, so happy to vote.
Yes.
Okay, thank you very much indeed. Next, 8.2 ICB Constitution. Jules.
Yeah, hello, I'm Jules Ellis-Bennett, the ICB Board Secretary. This is just to present a short paper. The board will recall that it approved the ICB Constitution at its first meeting on the 1st of July. Subsequent to that, there have been some slight amendments in terms of the legislation, and we received information 2 weeks ago, I think, yeah, that we were required to make some amendments. They are very small amendments, and they are outlined in the annex to the paper for you. They really are just sort of legislation numbering. At the same time, because this is a really sort of minor thing that we have to bring to the board, we are proposing a further change. As you'll see in the front of the paper, because currently the Chief Executive may periodically propose minor amendments of the Constitution, which should be considered and approved by the ICB prior to submission to NHS England. The suggestion is that we change that so that that wouldn't have to come to the board prior to submission to NHS England. So we're just asking the board to approve the legislation changes, that additional amendment, and then all the information will be submitted to NHS England in their procedures, which they issued in July of this year. There is a process to be followed. I won't say it's particularly quick. We could be next board meeting before we get a response, but we're doing as we're here. So now I'm happy to take any questions.
Thank you very much, Vic. Are there any questions? No. Very happy with that. Thank you. Thank you very much indeed. 8.3 report from the Finance Committee.
I think it's fairly clear from the executive summary and the points that were discussed, and in particular in terms of reference, I think still need a bit of work on it to get it right. And I think it's the first meeting of a sort of combined committee, so it's interesting. I think we've still got to find ways of working and what works best, but everybody's committed to making it work. So I think that was good. And we've talked about the risks in reality that are in the system, and that's what's gone up to, I think, all of the boards. Those risks in the systems are big, and that's what we've got to work on. So I think that's really all I wanted to say.
Just to be clear, are you, the terms of reference are approved, have been approved?
No, they haven't. They needed some more work on them.
Okay. So the next meeting of this committee is?
We've moved it to monthly.
Right.
We felt it was down for being bi-monthly, and we felt it needed to be monthly in view of what's going on. So the next one is in October.
Okay, thank you. Any member of the board want to raise any issues?
Just a slight, not in relation to the report, but in terms of our system committees, you're envisaging meeting face to face from time to time as well as virtually. Because obviously, face to face, you get a richness and a connection that you don't get over the screen.
Yeah, well, think about it. I think because we're trying to meet monthly to get everybody together, and it's such a diverse group, it takes up so much more time. So I think the majority will probably be by Zoom or Link Teams. But I agree with you. I think periodically we ought to meet everybody. So I think that will happen. But to try and get everybody together, and it's a big committee with all the DOFs and chief operating officers all in one room, I think it's a big ask. I'd rather they attended in reality than actually try and get everybody together.
You thought it was just having a mix, our latest clinical committee, about 50% came face to face, and I think there are huge advantages to face to face. And there were some people online, but just having that sort of option, that mix works really well actually for our clinical.
Yeah, I mean, we'll think about that. I mean, I find sometimes the mix of having half in and half out actually quite hard. It's in some ways,
it's difficult to navigate, but at least we then had quite a lot of people face to face, which I thought was really beneficial.
Yeah. It's hard enough trying to get the date from the diary at the moment.
Maybe once a quarter it could be.
And we'll perhaps put it in the future so people can get it in the diary.
Absolutely knows that is a face to face. Okay, Julie, thank you very much. This is now diving into the issues we were talking about earlier. It's safer with a plan. Yeah. Okay, thank you. Okay, no more comments on that. 8.4 is the Service Delivery Performance Committee. Dawn.
Yeah, so we also had our first meeting, very much an inaugural meeting, very much around positioning, what we're there to do, how we're going to go about it. So we had a very engaged, and super pleased with the sort of engagement from the trust members and the trust heads. We had it face to face with some online, and that worked quite well. So I'm really happy to continue to do that. We went through our terms of reference. They were pretty much there, I think. We just agreed that maybe we'd have 75% minimum membership requirements so that people were there and were engaged. That just needs to be added in. And we did talk about possibly having a lay member from time to time, but we will discuss that, I think, in December once we get up going and see how we're feeling about things and when we're kind of better positioned to judge. So, but other than that, we were pretty happy with the terms of reference. We looked at the kind of function map just so that the members were aware of how everything had come together. We looked at the Lincolnshire system plan, and we looked at the performance report, just to give everybody a kind of like a up to the same speed, all on the same page thing. And then we also discussed our forward work plan as to how often we will review the big key chunky stuff, and we have a kind of draft plan that we're going to take forward on that. So basically a set-up meeting, but went well, I think, and we kind of know where we're heading.
Excellent, right, and so all these cases will move from the setups to
we're straight in next month.
Straight into big issues,
including the winter plan. Including the winter plan, which will come just monthly actually.
Okay, any other? No. Okay, thank you very much indeed. And the report from the Audit and Risk Committee meeting. Julie, you're very kindly involved with this as well. So Julie, over to you.
I think again, it was a fairly standard audit committee meeting. Went through the internal audit plan and the external audit approach, etc. I think the summary probably sets it out. Terms of reference, I think, were approved at that one. Some work to be done on the risk management and staff, especially as I noticed the NHS have set out what they think the BAF should look like. So I suspect there's quite a lot of work to do as the year goes through on trying to get that right, probably for next year, probably now. But yeah, that was picked up and work to be done on it. I think that's probably about it.
Much. Any comments? No? Okay. Right. Thank you very much indeed. Thank you. Which leads us into the item 9. Before I just close the meeting, is there any other business that anybody wants to bring to the board's attention? Okay, so the next meeting of business, the next business meeting is the 22nd of November, and the next development meeting Tuesday the 1st of November. So business meeting will be a public meeting, obviously on the 22nd. Development will not be. So thank you very much indeed. Julie, is there anything else you want to say? No. Okay. Thank you very much indeed. That's the end of the business public meeting. Jerry, thank you very much indeed. And we'll call the public meeting to a halt there, and we will have a private meeting starting in 2 or 3 minutes. Thank you very much indeed. Certain people, most people will be here, but someone. Thank you very much indeed. Thank you.
Stay.